And that's the circumflex trying to come in with the wires in there. There, the ostium of the LAD has that disease, but I have already dilated it, so it becomes a little bigger. And that's the left main. And the left main is nearly 1, 2, 3, 4, 4.5 to 5. It's 4.5 to 5. And till the ostium there is plaque. Can you see there is plaque?
Yes.
From 12 o'clock. Till the ostium of the vessel? Yeah. So we're just getting out of it. So that is it. So with that type of disease, because the circumflex angiographically, you can see how the circumflex looks after this. Come on.
Other important aspect of imaging is to assess the ostium of left main out LCX. If it is diseased, then you plan to.
Yeah, I can do a withdrawal IVUS from the circumflex also. We've just done it from the LAD.
Yeah.
Can we see this angio better? Yeah, but somehow, you know, if you see the angio,
yeah, it looks okay.
It seems that the circumflex is big and it is okay.
Yes.
Yeah. Well, actually, I have a comment. I have to say that what you did so far is pretty reasonable, because I'm actually more than convinced that we should use IVUS for left main evaluation, and particularly in this case, when you see this is a typical diffuse disease of the left main must be even bigger than that circumflex. And of course, in order to understand which is the real size, if you don't do IVUS, you're just eyeballing. And that's absolutely wrong. But actually, I have a question. Do you use IVUS in all your left main cases, or just in this case because
No,
it's really...
I use it almost in every case. Almost in every case. Left main, and I strongly believe that left main intervention should not be done without imaging. In fact, there is that Korean study from Park, one of the studies where only IVUS versus no IVUS, and he's shown a reasonably big difference of about 8% difference in MACE, if I'm not wrong. And I'm pretty convinced about it. Because and the other thing in left main is you have to assess left main angiographically, if you so want to, by thinking what it should be, rather than just trying to compare relativity. So you add the LAD and circumflex and say it should be at least 2/3 of the combination of the two. You know, that's a rough thing. In fact, we have done a study of IVUS size and angiographic size on left main, LAD, ostium, and circumflex. This is not published, and we have got an equation. You know, it's like a straight line equation, y is equal to mx plus c. So the true size will be nearly 1.75 times or 1.6 times the angiographic size plus 1.1 or something. Okay. So if you will come to that, if you try to calculate it, it will nearly come to whatever other calculations we have. But we've done that study, and doing left main imaging in most of the cases, you can get a good idea even on the angiogram. But I think for anyone who's wanting to do left main intervention or beginning or whatever, imaging is very important. That's what I think. So
one other quick question is, if you look at the osteo-LAD in the left main, there's not, as you mentioned, both of you mentioned, there's not a lot of plaque, but there's negative remodeling of the vessel. Osteo-LAD is negatively remodeled, a little bit smaller. Left main is. Does that change your strategy in terms of sizing, the plaque burden? How do you factor that into the decision making?
Actually, the issue of how much it is negatively remodeled and how much is the plaque burden, because I am showing you the IVUS pictures which are post-balloon. So, one can't be very sure of the plaque burden and how much has been squeezed or how much has been opened. So that is the only issue. But whatever it is, you have to get an idea what it should be. And going by that, I think I will size my devices and the hardware according to that. You'll try to assess, seeing the normal LAD and the normal circumflex zones, what should the left main be, and then do it. I don't know whether you can you get what I...
It will not be totally normal in this case. This is a left dominant circulation. The ostial of circ will be affected although not very significantly, but there will be definitely 30%, 40% because distal left main is involved, ostial circ is involved, and left dominant circulation. This circumflex is equivalent to 2 vessels.
I think we'll proceed further, sir. In the interest of time. We can proceed.
Yeah, sure. So I'll choose a stent which is I think about 24 to, because I need to cover till the LAD. I will probably have a 4-0 stent right till the left main ostium, and then post-dilate the left main part to 4.5.
Yeah, this is the advantage of the later generation stents, which can be expanded proximally with a bigger balloon compared to the previous generation stents.
Yes.
And we also have the advantage of LED is also good sized here.
So I'm going to use.
Okay.
So let's see. So we'll use one of the newer generation ones, abluminous or something. Like, can I use a 420?
I guess the one question that's raised is it,
okay.
you know, should you routinely IBIS in both directions? Is it going to change your plan? Is it worth IBIS in both directions?
But here the circumflex looks very good, so I am not doing it. Otherwise, you could do it both the directions. We can do I thought I will put the stent and then expand the side holes and then do the IBIS on both the directions. That's what I was thinking.
Particularly in this case, I guess that testing the left, let's say, the circumflex with the IBIS will probably not add much on top of what you already see, because, you know, what you actually ultimately need to know is the size, and definitely the size of the body of left main particularly. And then maybe afterwards you can check, but definitely looking at the anatomy, I would say that although there must be some kind of involvement of left circumflex ostium, there's not be, you know, a big of an issue.
True, and I guess the size discrepancy from the LAD insert is interesting here as well, right? Yeah.
Abluminous.
Dr. Luca, you have experience of this stent. I believe you can pass on some comments about it.
Well,
This.
actually, I lost the size of the stent. Which is the stent?
428, I think. What the
420. Okay.
424.
This is 424.
That's good for the implantation.
But anyhow, this is 24. So now what I'll do is I'll place the ostium first, and then wherever it ends.
Yeah.
If it ends short, we'll have one more. No problem. Test.
Very important to check in the cranial view again, elevocranial and epicranial, because sometimes many of us tend to use caudal, but you may not assess the ostium right. That's how it is being positioned in the ostium carefully.
Angio, please. So you see, you're seeing the ostium very well.
Yes.
It is the true cuspogram. The sinus is there, and you see where the vessel is arising.
20 again.
That test, please.
And the worst thing here is to fall short of the ostium by 2 or 3 millimeters, because then you get the edge injury, restenosis, and you make the next intervention more challenging. So you need to be 1 or 2 millimeters out rather than risk being short.
Suppose by chance if you fall short also, always place well in the ostium first and then distally you can tackle later if at all.
Test, please. I think this looks okay.
You can come here. Can you somebody give mic there?
Okay.
They're getting.
I have done it. Yeah. I saw it on the ostium and I think it was okay. And distal we'll see in the epicaudal view. So the pressure of 12. So this has actually medication only on the abdominal side, the stent. So the total total drug load is less, and probably with that you could have lesser thrombotic events. Although now the stents are pretty good, I think, with those thinner struts and lesser drug.
Can I make a comment, Praveen?
So can we?
Dr. Vijay Bang here.
You can tell me, sir.
Yeah. The comment is
now you see this.
that the
now
angle of
it,
left main to LAD
you are seeing
is very favorable. It's called as main vessel angle.
Sinus, and then it
has
opens into the
for
sinus.
a provisional stent.
So there is no miss, and this is the best view I can tell you.
There's a question or comment from the audience.
Now, yeah, please. Looks good.
Yeah.
So that's what I was saying, that it is very suitable for provisional stenting.
Yes.
Because the left main to LAD angle the upper angle is high. That angle, if it is high, it is very suitable for provisional stent.
Yes.
Second, ostium of the circ, usually if it is more than 10 millimeter into LCX, the plaque involvement, then of course you will require some other stent. Otherwise, no need of any other stent. I think provisional is good enough here.
Okay. Now I think you will wire through another wire into the LCX and then post-dilate, or you will post-dilate, do pot and then...
No, I will post-dilate first. I will post-dilate first. The principle of any, this has become the bifurcation. Agreed, there is the side branch stenosis is not there. But then what I do is post-dilate first so that when I put the second wire, it doesn't go under the struts.
Yeah. So preferable to use a
so I will post-dilate first, and this wire which is lying on the side doesn't create any trouble, I can tell you.
Right.
And the other thing I wanted to tell you was I have done everything through a 6 French guide through the radial route. So, so some people might be scared to do a left main on a 6 French. So there is really, only thing is you cannot put 2 stents together, but otherwise you do 1 stent, 1 balloon, 2 balloons, it all works.
Okay. I think you can continue working, sir, and do imaging again post. We'll come back to you in the last 10 minutes.
The final,
We'll go to Dr. Pratap's center and come back to you. Over to Column.
Right, sure.
Pratap, I'm Dr. Srinivas Kumar here.
Yeah, good morning, Srinivas. Good evening, Srinivas.
Yeah, good evening. I have Dr. Sushil. I have Dr. Sushil Kodali, Liuka Testa, Eshpal, Mukesh with me. Ajay couldn't join, but Dr. Sushil is there in this place. And please go ahead and introduce your case, and we are eager to see you what sort of CTO you are doing.
Sushil, Srinivas, we are actually, we'll start with our case. My colleague, Dr. Manu, will present the case.
Okay, good evening all. Our case is a 60-year-old female, diabetic hypertensive with history of class 2 effort angina for last 1 year, developed with the TMT, which was strongly positive for inducible ischemia. Angiogram done elsewhere showed single vessel disease, posterior proximal long segment CT of the LAD, and no flow limiting lesions in RC and circumflex. And they have attempted PC to proximal LAD CTO through antegrade approach to nearly 2 months back, but they couldn't succeed and so abandoned the procedure. Now patient came here for PCI.
We'll show the first angiogram. Today's angiogram we will show you. This is the first angiogram. It's a non-CTO from the ostial LAD. Since it is an attempted one, we tried with a retrograde. So there are multiple collaterals here. We can see a septal collateral going up. Can you just freeze it up? There is a connection from the PDA. It's a small branch coming up and connecting, but there's a doubtful connection in between. Then go next. We have some epicardial collateral connected from the acute marginal going up to the mean middle AD. Then there is a cornus branch coming up and connecting with the LAD in the proximal part. So there are three connections, 2 epicardial, 1 septal collateral. We tried. Next. We have kept a wire that is called turn track wire in the LAD just for a RCA just for the support. Then we took a caravel with a cyan black wire.
Before we go forward at this point, can you give a little bit of your
Just stop.
thought process and how you approached it? You mentioned earlier that you or others had tried antegrade. So in terms of the technique, how you're going to approach it, what is your strategy up front? Just for the audience in terms of guide choice. And I think one important point is, I don't do CTOs, but the key part of a CTO is the planning, but also your angios up front. You did a large field of view, you did in pan. And I think that's a key aspect that experienced operators do. You go back to that first angio, you could see everything and you can study it. When you start panning and doing multiple things in a small view, those would make it difficult. So if you could just go to this view here that you have and let us know what your thought process is when you see this and how you're going to approach it. Antegrade, retrograde, wire choice, escalation, what is your thought process?
if I can add on top of this question, which I
Actually,
totally
Sushil,
agree. I would like to know, first of all, and this is for the sake of clarity, what is the main reason not to even try antegradally? Because I see that in this, particularly in this view, the CTO, particularly for antegradal approach, is pretty short. So actually doing CTOs since more than 5 years, I will actually know why you are not even trying to do antegradally but just going retrogradal, because you know there is a lot of debate about hybrid approach, retrograde first, antegrade first. I mean, there are schools like in the US, like in Japan, like in Europe. So what is your process of understanding what to tackle first?
Pratap, when do you prefer
usually
retrograde
my approach
versus
is actually when somebody, that is what, actually when you try somebody antegrade, already attempted antegrade, first attempt will be a retrograde for me. And number one. Number two, if a calcified CTO, long CTO, then also again I will try a retrograde. So these are the two situations I prefer: a tortuous anatomy where the ambiguous anatomy antegrade. That means osteoproximal LAD, osteoproximal circumflex CTO, osteoproximal RCA CTO, I prefer retrograde. So retrograde is preferred if a failed antegrade, a long calcified tortuous CTO, or a osteoproximal CTOs, either in circumflex LAD or RCA.
In the initial antegrade attempt, were they getting to a dissection plane, or were they not able to enter the proximal cap? What was the mechanism of failure in the first attempt?
Sushil, actually we don't have a series of that. So I thought maybe a dissection plane is created there. I will try retrograde. If I fail, then I'll go antegrade and try with multiple wire escalation.
Wonderful,
Okay.
thank you.
I think you can go further. Proceed.
So next. See, we tried retrograde next with the, it's a caravel with the first wire is a 10 track wire just kept for the support. Then this is actually a wire with a cyan black. There is a connection I created. There is a long, actually a acute angle there, so difficulty in taking the branch down. I took the wire down. And pushed the caravel down along with that. Taken the caravel out and we took a Suhotri wire.
I actually have another question, if I can. Do you routinely use the Judkins right for retrograde approach, considering that, you know, probably the majority of the operators would have taken an AL1 for this kind of indication, considering the need for support? What is your approach in terms of catheter and support determination before planning?
No. Actually, Luca, basically, if there is a real good support with an JR, I take a JR. Otherwise, if there is no osteal disease, I may take, because I was planning to take this cornus branch. Since I wanted to take a cornus branch, I was actually thinking cornus as a second choice. So since I wanted to take a cornus, I did not take an amplats, because amplats may go deep inside. I may not be able to take the cornus.
I see.
Always, if possible, we try to avoid your
Otherwise, I will be preferring to.
Okay.
Yeah, damage to the vessel. So this
Yes.
I tried with acute marginal. Again, I failed there. Next, this is actually a cornus artery I took. Actually, because of the severe tortuosity, even a Suhotri wire, multiple wires I tried, but it's not entering inside. So I don't want to damage the cornus artery. So
I think it's important to sort of point out, though, when you go through those type of collaterals, epicardial or conus, they're much more fragile than the septals, and the potential risks are probably a little bit more as well. So, you know, in experienced operator like yourself, Hans, I think it's reasonable to try, but I think for people that don't do a lot of CTOs, these are things that I would be very careful with.
Generally, septal collaterals are to prefer to our epicardial.
Sushil actually, it's actually perfect, because since the septal collateral I did not get, I took with epicardial. But whenever I take an epicardial, I'll be very careful. I don't want to damage the epicardial and not to create a perforation. Once you create a perforation, it will be end of the procedure. Yes. So I was trying my level best to take into the vessel, but that because of the tortuosity, it is easy to take a caravel up, but the tortuosity will not allow the Suhotri to go up. Next.
For some of our friends who couldn't join here, you can inform our entire proceedings are being relayed live on our website as well as on YouTube. If somebody cannot join here, they can watch if some of our friends are interested. Anyway, go ahead, Prasad.
So this is the situation. Now I shifted the wire, but that is also not going. Probably I will try an antegrade now. This actually, you see the tortuosity there, very difficult.
Which wire is that?
See, the wire is actually taking, this is actually, I tried with the Suhotri, failed, then I took a XTR.
Normally many of us would not that comfortable with retrograde would try antegrade and then go retrograde if one fail. You are doing the reverse. CTO specialist.
No, I'll try antegrade. Can you just give me a wire? Now I'll go to the antegrade.
If you see a small track positively, I think that helps us to edge more
Basically,
towards
you see, it is a ostial. You see,
small
you can't
stump.
see that very well.
You can see an entry point there potentially,
small
right?
tap,
Yeah,
entry point.
there's a peak there.
After the first attempt failed antegradely, you may actually end up in the same situation in the section.
Yes.
And but of course there's a problem, but I have to say that at least the first half centimeter is into the true lumen. So at least you got an indication where you have to push, because it seems like it's relatively straight, although it's calcified, maybe dissected and whatever. But looking at the retrograde possibilities, I have to say that all these tortuosities are just a nightmare. So, you know, I will try anyway.
What is the wire you are taking for antegrade?
Basically, this is an ostial. Now, antegrade, I'm taking a XTR with a fine cross. XTR with a fine cross. The problem is actually it is ostial CTO. You may lose it by just one pushing of the wire.
Okay.
So that is why I was thinking that it may be a real tough time, because you can see a small track there, but I don't know whether it will be easily going inside.
For sake of delegate audience sitting here, whenever you feel there is a small antegrade track, nowadays we have this fielder XTR wire which generally tracks well through it. And if you are absolutely sure that there is no track, then you can take directly stiffer wires. Most of the times, whenever you feel the faint track is there, you could get away by doing a fielder XTR which has a 0.09 thickness and is more slippery and could go easily whenever you have any faint channels. So whenever you suspect a faint antegrade channel, use that. And when you're absolutely definite that there's no channel, then you can use more stiffer wires. I think there's a possibility of faint track. Only problem here is when people who it is tried elsewhere, the track could be going into dissected path. If it is of some time, it is okay. That's the only thing which you need to worry. And these wires also tend to slip into wrong tracks too.
The guide here seems a little bit big, making it a little more challenging, sort of pushing you, not angling you towards the...
LCX.
Yeah. This is an EBU 3.5 or?
Guide is
EBU 3.5. Guide is sitting towards the circumflex. That's the challenge here.
Yeah. Generally,
guide is sitting towards the circumflex.
Generally, LCX we plan 3.5 and LED you tend to take 3. Maybe because of a bigger size, you must have planned for 3.5.
But you can see 3.5 actually. We take always a 3.5 or 4 in CTO because you will get more support.
More support, right.
More support with a larger curve. 3.5 or 4, you get a more large support. So otherwise you have to take an amplats, because I was thinking that it is not required amplats here. So that's the second choice of, if retrograde I fail only, I was trying for an antegrade here.
You always take the help of a microcatheter like Tonus or any other microcatheter with this wire, or you would try before without that for free movement?
Tonus, I don't, Tonus, no, I will.
Yeah, some sort of support.
No, I will always take a microcatheter for CTUs.
You try sometimes even without the
some
taking.
microcatheter I always take.
Always take. Okay.
Yeah. No. Always name. Actually, some of the situations I try with a microcatheter, without microcatheter also sometimes I try. If there is a real, if you feel that if it is successfully, and it is high possibility that you can be successful, then I try with that other also.
Okay.
See, the wire is not sitting there. I'm actually pushing my microcatheter so that even if I wanted to take a tougher wire, I can take with that wire. If I am sitting
This is
towards
actually one of the limitations of the feeder wires, because they are very slippery, lubricious, but the torque ability is not, they have been created actually to navigate into microchannels.
Yes.
So when you have bends, they are actually in trouble. So, unless you can achieve a better position with the tip of the catheter, it's going to be a problem, because of course, although you may customize the tip, still the torque ability will be poor. These wires have been created to navigate into microchannels. That's what they do.
Yes.
So sometimes can be a problem if the position of the tip is actually going towards the LCX when you have to take the LED. But I think that some kind of manipulation may help.
So if this doesn't go, options are change the guide to EBU30 or use another wire to help engage the lesion, get the microcatheter in, and then switch to the XTR.
That's right. One option would be exactly to put a wire into the LCX, actually to adjust the position and the angle of the tip of the catheter, but still there are some possibilities. It depends on your practice, actually.
And one thing you have to be cautious about when you're doing this is you get so focused on the LAD CTO, you forget you're working left main circ, and you get into a dissection that's just proximal, and then you end up dissecting down the circ, and that's what you have to be very cautious against.
Yeah.
Ideally, Sushil, you have to put a wire into the circumflex and keep the LMCA to be preserved, Right. That's actually the ideal situation. Here I'm thinking that there is a possibility that I can put the wire at any point of time.
Another option could be to use a very torqueable wire like cyan blue or something, just to get into the stamp and to navigate with the microcatheter and then exchange. Because, I don't see any potential for the field to get there.
Cyan black.
I agree.
We will be going to take a cyan black now.
What is your most preferred wire nowadays for CTO?
I actually take a cyan black or a cyan wire as the first wire. Then I will switch over to XTR if there is a micro channel. Then I go to Gaia second, then Gaia third. If there is no possibility of opening up, go to Miracle 6, Miracle 12 and Congress Pro 12. If this graded escalation is not possible, then we will go directly to the retrograde. And if fails, reattempt. That's the point.
Apart from the CTO scores, calcification, long track, which are all worrisome, what I am always worried is it's attempted elsewhere, it's failed. I think we need to be more careful and plan our procedure well, because there could be some trouble created with the previous procedure. And if it's sometime lost, it is fine. But if patients come very early, I think you need to be more careful.
I make a double curve in this case because the vessel catheter is actually facing towards the circumflex. That is the major issue here.
Yeah. Pratap, as you are trying with another wire, Pratap, as you are trying with another wire, can you go for 10 minutes to other center and come back? Is it okay with you?
Yeah, please.
Okay, we'll come back. We'll come back for last 10 minutes to see result. Can you go to sir, Dr. Goyal sir, we are with you again. We are live.
Yeah. Okay. So as I told you, I had put the stent. You saw me putting the stent there.
Back.
You saw me putting the stent there?
Yes. We saw the picture after stent immediately. You were taking post-dilatation balloon. At that stage, we left you.
Back.
Yeah, so then what I did was I did a post-dilatation with 4.5 NC of the left main, okay?
Okay.
And after that, after the post-dilatation, I have just crossed the circumflex through the struts and pulled out the other wire, the one which got gelled. Okay, so I still have 2 wires now, and then I wanted to do some imaging and see what the result was, how the stent has expanded, and if there is any distal dissection or anything. So this is the epicaudal view which you see, the final picture which we have. So I will show you the areocranial also.
That's areocranial.
I think, yeah, that's the areocranial. So it looks all right, and the circumflex looks open. So, but to confirm with imaging, this what we have done, then I did a OCT.
Can we have an aleocaudal view to see the LCX ostium once aleocaudal is done? Okay.
Yeah, sure. Let us see.
What size balloon did you post-dilate the left main with?
4.5, sir.
4.5, okay.
4.5. Come on, inject. It looks okay. Actually, angiographically, it looks pretty good, I would say. Angiographically, it looks quite all right. Because there is no pinching at all. So you don't get any indication to do a balloon across the side branch. If there were some pinching, you could have thought of doing so.
One other thing shown clearly is the ostium is covered very well, and there is no left main. Now directly it is going to guide, and that shows.
Yeah, left main. You see the cuspogram, and you see again. Still here there is a little overlap on the sinus and the vessel. Can you make that out? Because this is aleocaudal view. Some people considered aleocaudal as good for ostium, but this is what I teach all the time.
No, that's what we discussed. Cranial is always preferable for ostium. Yes.
Yeah.
Can you actually look at the, as you can see, this stent rendering is giving us an idea about the apposition of the stent. What is right? It means that the distance between the stent struts and the arterial wall is less than 200 microns. When you see the red color, it means that it's actually larger than 400 microns. So there is just a small segment, according to the OCT angiogram, that is still red. Can you actually look at that and show us? Because apparently there is a very small malapposition, or maybe under expansion. You see the red segment?
Yes.
At this point, yes. At this point.
Because it can, you see, maybe 4 o'clock to 6 o'clock, there is still malapposition.
Yes.
Correct.
Actually, you can rotate it 3D and also confirm it, how it is looking.
Yes. Can you please rotate the image?
At that point, rotate the OCT at that point.
Can you rotate it?
This tool is very helpful because it gives you immediately an idea of what to do next. As you can see, there is still, in the very proximal edge of the stent, need for post-dilation. Maybe the 4.5 was not enough.
I think what's important with also doing osteal left main when you're irising is make sure your guide is back, that you're imaging appropriately, you're seeing the true osteum.
Well, and I have to say you can anticipate that because the left main is so big.
Because we also did a withdrawal from the circumflex.
Not enough.
And can you show the circumflex hole on the 3D? We can also see the hole of the circumflex on OCT. So actually post-stent OCT is, I think, good. Because sometimes OCT may not give you imaging till the depth or the 3-layer structure. So the sizing may not be correct at times, maybe. Although if you get the 3-layer structure, you can still get the sizing. And especially in left main. So what I usually like is if it is a post-stent, then OCT could be there.
Yeah, now you're seeing that ostium, that bifurcation view or whatever you call the ostium of the LCX.
Yeah. Can you see that? Yeah. Osteum of the LCX is beautifully seen.
Yeah. This view, it also shows that the wire into the circumflex actually went through the proximal struts.
Okay.
Yes, this is a 3D navigation and reconstruction of, according to the OCT, and it's the only way to clearly assess what is the position of the wire into the side branch.
Can you
Clear stent?
take it?
Little back, sir.
I mean, OCT is a very powerful tool post-stent compared to Ibis, right? I mean, you talked about the benefits of Ibis pre in some of the assessments.
It's also very scenographic
It
because it
shows
shows
very
you
attractive.
Do it. Clear stent again?
beautiful
Okay,
pictures.
please.
Yeah.
The only place where Ibis could be preferred is in the osteal involvement like this,
Yeah.
where sometimes there
I
could be
think
challenge.
overall it's a very good result, but
Yeah.
still there is something to do at the very proximal edge of the stent.
Other thing which is important while doing POT is to see what is the distal extent of the balloon going. You're supposed to just be onto the proximal part of the L6 origin, do not cross the L6 totally, so that there will be less of problem of L6 when the left main stent expands well proximal to the bifurcation.
It's okay.
And I have to say that
You're
this is
taking 5 mm balloon? What are you doing, sir?
Okay.
You're taking a 5 mm balloon post-dilating?
This is 4.5 only.
You did 4.5 already, no?
4.5 only.
High pressure.
Yeah, because this is, no, that was the proximal most end and the pressure I used was only about 16.
Okay.
So I'm trying to go a little higher on pressure, this time about 20.
Okay.
And I am slightly on the outer side, so maybe that will make a little difference.
I've had only a general comment, I have to say. This is actually the beauty of doing imaging for the left main. Because if you look at the angio, you will never anticipate that that stent is not very well opposed. You will say it's finished,
So
it's
we will
done.
do one
Nevertheless,
OCT.
if you look at very carefully with Ibis or OCT imaging, actually, you see this kind of things. And we all know how important is the apposition for the stent failure in the follow-up. So particularly for the left main, I would say we need to use more imaging. Overall.
More imaging or more OCT? So, but the area there was 14. At the area of malapposition, it was 14. What, I mean, because again, what are you striving for?
OCT in the left main can actually give some hurdles because of the need for more contrast, the need for large volume sometimes because the left main is big, but also it takes some more skills compared to Ibis. But you know, in expert hands.
This what he wants to highlight is here we are started using one new type of material which is a colloid, which is tetraspan, which is of I learned it from SGPJ during my live transmission in NIC recent conference. So instead of using a contrast, sometimes when you're worried about it, use this injection. You get very good quality images without the use of contrast. My nephro colleagues were also worried whether that is also
all the images I saw
but it's okay.
were without contrast. This is all, we use Hemexin?
Tetraspan, sir. It's a colloid.
Yeah, tetraspan, you are taking that now, injecting?
Yes, sir. It's tetraspan only we're injecting, sir.
Yeah,
All the runs we did with tetraspan only.
Okay.
Ready?
This is contrasted.
Yeah. This is actually the co-registration because it's acquiring in the OCT, actually emerging in the OCT information with the angio. And it's actually the best way to look at the real situation after stenting. I have to say that, you know, there is no competition Ibis versus OCT, but it's just a matter of, let's say, technicalities, because if you are not used to use either one, of course, you just rely on what you know.
Yeah, we are having a live webcast coming with Gary Mills talking on advantages of each technology after some time. I think we'll hear more of it. But for youngsters to learn, for novice to even imagine what it is, OCT is very easy to learn and I think very catchy pictures. With the three-dimensional reconstruction and it looks more user-friendly to learn. Only disadvantage is the contrast. If you can get away with it, I think it's better.
Yeah, and I have to say that particularly in the left main setting where you may need to do the imaging plus, well, several times, the OCT can be a problem of
several images.
Particularly when the patient has some renal failure and so on.
Yes.
But still, it's not a contraindication, of course. It's just a matter of, let's say, being used to. But definitely, if you look at the pictures with the OCT, wow.
The other thing which we need to be careful is whenever the vessels are angulated, sometimes that tends to get separated while pushing. You have to maintain the coaxiality and then push it. Right. Especially when going into LCX ostium, sometimes it could create trouble, the OCT thing. Though the point of initial challenges was when you're threading it onto the wire, it was difficult, but the latest catheter, that worry is gone.
Now it is easily enters without going into that crystal space. Another point of worry was whenever you're using such stents across, whether it will cross into LCX. Many times patients have gone when we had trouble distal LCX, we could easily cross with the latest generation stents into the LCX without much of problem. Even without predilatation, we could sometimes enter easily. I think we have excellent demonstrations, sir. I think we will take one final picture and then see that red thing which is Mala post is gone. And
auto calibrate. Enable. Enable. Okay.
Okay. One final picture, then Bhatia says we have to.
Picture is there.
Let's see whether it come on. Yeah, it's okay. It will get.
Are you? Because it gets you the stent 3D only when the pictures is absolutely.
See, this is one of the limitations of the OCT because you have a lot of streaming of the contrast because actually the OCT technology is based on the blood repletion, so you need to substitute the blood with the contrast. And of course in the left main, such a large left main can be a problem. Anyway, of course in expert hands, we can have these beautiful images, but let's say, generally speaking, that OCT can be technically complicated for left main assessment.
The pictures are not good.
Anyway, I think overall it looks good, sir.
I think, that's technically.
Congratulations for excellent demonstration of usage of imaging. Both you have the luxury of using both Ibis before and OCT after. That's how I think it can be used, because initial assessment is always done with osteum, especially involved with Ibis, and then stent pictures are very well shown with OCT. Thanks once again for all the cooperation and help. He has been always a great source of encouragement. I think Hall is clapping you, sir. Thank you very much.
Okay.
We'll go to Pratap Center for last.
Thank you, Srinivas. Great.
Thank you, sir. Thanks. Can we go to Pratap for last? Pratap, we are with you now. Last few minutes. You want to say?
Yeah. Actually, what I tried, what I tried is actually I'm not able to pass the wire down. What I did is actually I switched over to the catheter. Back. See, this catheter was not able to go. Then I switched over to 3. EBU 3.
Okay.
Next. I switched over to EBU3, which was looking exactly into the LED.
That's what Sushil
So
was
I
mentioning.
took a wire again, a cyan black, that into the LED now with the microcatheter. Then what I did is actually I pushed the wire. This actually I switched over the wire into Gaia second. Gaia second crossed the lesion. Once the Gaia second crossed the lesion, it went into the diagonal. Then I kept the microcatheter in the proximal part. Pushed next.
That's why it's very important. Many people think guide support. The guide support is not important. The positive angle and coordination and direction of guide becomes very important, especially.
Sushil was asking which wire. The first wire actually, the cyan black actually, with the help of cyan black, I went into the proximal cap. Then lesion was crossed with the help of the cyan black, Gaia second with the microcatheter.
Okay.
Now I removed the microcatheter. Now I am actually taking the balloon inside. Now wire is in the distal part. Now I cross the lesion.
I have to say that this kind of situation are really hard to anticipate, but it can happen that after the first attempt of antegrade approach, after this dissection, you can have a process of positive remodeling. So in that case, the artery gets bigger, so the second attempt of rewiring antegradally can actually be more facilitated, I would say. I will not say easier, of course, but definitely you have a higher chance. This is why actually the second attempt is always better than the first, because you know what you have to do. And the job done before can be helpful, despite it wasn't actually a failure. You see that that's pretty normal. This is pretty normal. Now this dissection is visible because the antegrade injection fills it with contrast. So that's why you see this dissection. And basically when you are crossing and CTO, you are always creating the section. No matter what, you are doing that. Now is...
No, I think it can be even created by the balloon also. I would have dilated with the balloon with the 2.5 high pressure. So that also would have created dissection.
Good dissection, good preparation.
So the CTO ended at the bifurcation of a diag. Would you put another wire in the diag now, or would you?
I think so. I think so. I mean, the diagonal looks reasonably good.
You can end at the junction.
That's the question. Do you have to put another wire and try, or would you image at this point to see if you're true lumen at the level of the entry?
No, we have to put a ideally, Sushil, before putting the stent down to the ostial LAD, we have to put a wire into the circumflex before doing that, because all LCX.
Yes.
Yeah, that's always very important because of the, see, we have ostium is very well seen, and you have like a T shape. So even if there is a problem, we have a chance. It is almost like a T. We can exactly put the stent at the ostium of the LAD.
Now you
By
can
definition, we really don't know. The ostium is really tight.
The right guide and wire, can you remove now?
Right, remove. I am going to remove. Yeah, everything I am going to remove it. I just put a wire into the circumflex and then we can do an Ibis and see what is the size of the LAD. Probably it look like, circ is looking like 3.5. LAD looks like 2.5 by angiographically. I think it will be 2.753 minimum. What do you think?
Yeah. No, I think it's got to be at least 3, and this is where, especially in a CTO, there's negative remodeling, there's plaque, things look smaller. Where imaging may play an important role. I would put a minimum of 3, but it may be bigger if you actually, on imaging sometimes.
What is the size of the last balloon you used?
No, Sushil, actually the left main looks like 4.5 to 5 with a 3.5 circumflex. Minimum 3 millimeters should be the LAD.
Yes, that's what.
Luca, they're asking what size balloon did you use?
2.5. You said 2.5.
2.5. No, I used a 2.5 balloon.
It's always safer to wire LCX before do anything, because as we said, discussed before.
Yeah, I already put a wire. Now, whether I have to do an Ibis and to show, or I can put a direct standing.
We are left with you for 5 minutes, for 4 minutes in fact, Pratap. I think
4 minutes is sufficient for me to show the Ibis.
Stenting or Ibis? Okay. You can go ahead and show the
Ibis, anything, whatever you want.
Yeah, ideally what is correct we should show. You do Ibis and assess the vessel size, and then probably you can take the stent.
Yeah.
I mean, the rest of this is sort of cleanup and routine strategy at this point. So the Ibis and see the stent size and strategy is a more important question.
Yeah. Mukesh, anything you want to say?
I just would like to ask, sir, what would be your choice, antegrade or retrograde in this particular case, if you have to do it? You would first try antegrade and then go to retrograde, or?
First antegrade and then only.
And I would like to know the opinion of the audience. Majority would like to go with antegrade first, because Dr. Pratap is a master blaster. He can do anyway. He's a CTO specialist.
Whatever you're comfortable with, first that should be done. Then I think, then when you fail in that, then doing all other things come.
Okay, Ibis.
Can we see the Ibis?
Now?
No.
Show the Ibis image?
We can't see it yet. There we go. Now we see it.
Can you? Okay. Severe plaque, actually, large plaque. You can see the plaque. It is totally in the lumen.
Minimum 3.
Will look like a 2.75. Yeah, maximum 2.753. That's all.
Yeah.
3 millimeter is the stent. Now it is very, you can see the severe disease in the osteoproximal part. I think you have to do some more dilatation in the proximal part before putting the stent.
You see the nice dissection there.
Yeah, dissection is seen.
A dissection also you can see, but there is a severe, plaque is severe.
Yes.
Now comes to circumflex. Circumflex osteum will look no disease, and LMCA is look like 3, 4, 4.5. 4.5. back. So 4.5 circumflex, I will put a stent exactly from the ostium. I'll try.
Yeah, I agree.
So
I mean,
we will put
even
a 3
if
millimeter
one
post that
strut
again
will be
that
hanging in the left main, nothing's going to happen. It's so big that you can afford to do that. But also, I would like to draw the attention to the fact that the Ibis nicely showed that the wire is exactly into the true lumen. So we didn't see any effect of in and out. So the dissection is a consequence of ballooning and maybe of the previous procedure. But definitely this wire is in the true lumen. So you can actually transform this in a conventional PCI from now on.
Yes. I think what is you planning to take which stent? 3 2?
I'll be 3 into we will be putting a 3 millimeter stent 3 into 18 or 24.
125. I think the proximal portion can be optimized.
3.25 size by the Ibis.
Okay.
Yeah. We have to take a 3.5 millimeter post dilatation by 8 millimeter, 3.5 in the 8.
When you have to exactly position the stent at the ostium, probably stent like Zines, which has a marker, exactly starts where the stents could have some advantage in its ostial placement.
Yeah, exactly.
I think, Pratap, we are worried that Bhatia says we might lose you at any time, but we will be with you till then. And thanks for excellent demonstration. And then again, antigrade technique could solve the purpose in this, and then retrograde was challenging. Sometimes life is funny, it shows different ways. And we have seen Goel showing one left main crossover, and we now saw the ostial LED opening. We'll probably finish it with positioning it right from the ostium to the LED, and without coming anything to LCX. Any final comments, Pratap, before we close?
No, thank you very much again giving me a chance along with Srinivas, always give me a chance to do some demonstrations. And this time it is a third live show I am showing in this year with IGCTO 1 and 2 with Srinivas. Yes. Thank you, Srinivas.
Thank you so much
for giving us a chance to show all these things.
And Sushil wants to welcome you to TCT USA in San Francisco.
Yes, okay. Look forward to it.
Sure,
all right.
Sure.
Thank you again.
I'll be there, Sushil.
Okay.
I'll be there, Sushil, on day after tomorrow.
Actually, I requested him to conduct our CSA NIC session in there in TCT San Francisco. Thank you. Congratulations. Let's give a big round of applause to Pratap. I think hall is, could you hear those? Anyway, thank you very much, Pratap. We break and we go on to the next session of lectures. Thank you.
Great, thanks. That's one nice way to start off with some nice demonstration with live cases, left mean, and CT of the LED. We'll move on to our next session. Dr. Mehta is going to move on from imaging to physiologic guidance for lesion assessment pre and post PCI.
Is Dr. Harish arrived? Okay, please. And there is some slight change in the schedule because we also had Santosh Satish joining a little late, and Luca has to leave tonight. We will have both of his lectures of Luca from next. He'll be presenting 6:10 to 6:25 one, and then 7:10 to 7:30 will be his second set of lectures, one on regulating balloon and other on the newer stent technology. Over to you, Dr. Harish.
Hi. I'm going to begin. Thanks, Srinivas, for having me over. Sorry, my flight got delayed and I just managed to go in. So you're giving me a difficult topic in 10 minutes, 10 commandments for physiological guidance for lesions assessment and pre-post PCI. I hope I can do justice to it. And hi again, Sushil. We met in Sentient. Okay, this is when really physiology started, when angioplasty started. He measured the pressure gradient across the lesion when he was ballooning. So that was actually the birth of interventional physiology along with the interventional cardiology. So these are lesions we keep dealing with and we don't know how many vessels to touch, what to do, where to send them. So we need something more than what we really do. So why physiology? That's my first commandment.
I see Dr. Badrinath here. Can please join? We are supposed to be one of the panelists with us here. Please join on stage.
So if you realize that by definition, approximately 12% of elective PCIs were inappropriate. So we have to be very careful when we offer PCI to our stable angina patients. That's why physiology. And the non-invasive invasion, we won't go into like PET, SPECT, we won't go there. Tools during PCI are mainly FFR and resting indices, imaging, FFR CT, which is coming up in a big way, hybrid catheters, near-infrared spectroscopy. All we know from FAME, everybody knows that FFR without an angio-guided, we realized that the outcomes were better with FFR guided clearly in terms of death, MI, and MACE. And these outcomes were maintained up to 2 years follow-up, and up to 5 years follow-up, they were parallel. So that clearly showed us that we use fewer stents if we use FFR and less resource utilization in the long term. Similarly, the FAME2 did the same thing when they did optimal medical management with PCI versus optimal management and registry. They found that when you do FFR, the PCI plus optimal management does very well, equivalent to registry, and only medical management in patients with FFR, they don't do well. So FFR clearly told us the way out in chronic stable angina patients. And the DIFFER study was the longest. They gave us a 15-year follow-up. An interesting finding they found here is that the MI rates were down in patients with DIFFER. So that was again another evidence for us to go for physiology. Then comes which one should we use? Should we use hyperemia or non-hyperemia? So we have hyperemic indices which are FFR, but we have lots of non-hyperemic indices which are used, the IFR, commonest, RFR now coming up, diastolic flow ratios, PD by PA, but they have different cutoffs, 0.8, 0.91, 0.89. Now how do they hold against each other? That's very, very important. So these are the lesions which you see, intermediate stenosis. Only one lesion here is discordant where the FFR was negative but the IFR was positive, the other two were concordant. So it was decided to simply stent crossover, leave the circumflex alone for the moment because the FFR was negative, and the predictability was quite good. So what IFR told us that it was highly specific, although the sensitivity was low with IFR. And again, tandem lesions, PCI, you can use a combination of IFR and FFR. So you can use both of them together to save time. And of course, to save the side effects of adenosine, although they are short-lived. So different lesions treated differently, left main, RCA. You see the IFRs are different. But you need to understand when you have a tandem lesion, the difference between the two, bigger the difference of FFR, that is tighter the stenosis. So in this patient, the distal FFR difference was higher, so the distal region was tighter, which you can see here with the graph here. So we did the LAD diagonal first, and then we just did a simple IFR to the left main. You don't have to do an FFR again, just do an IFR. IFR was positive. You go ahead and stent the left main and complete the job. So what it told us, that compared with angiography alone, if you use availability of IFR pullback, it altered revascularization procedure planning in nearly 1/3 of patients. So the conclusion that although there is a disagreement between the two in approximately 20% of cases, however, this disagreement has not been translated to clinical outcomes. So whether we can use this or that or a combination of both is still a debatable issue because the outcomes haven't changed much. Now, angiographic left main, this is the biggest problem which I think everybody has. The inappropriate decision based on angiography can be as high as 30%. So these are the kind of people who will probably have a wrong decision based on angiography alone. So what is the problem with osteoproximal? That's the fifth commandment. Always prefer IV adenosine for left mains, don't use intracoronary, especially the osteal lesions. And you have to disengage the guide while you're doing FFR of such patients, because that's very, very important. Otherwise you get a false FFR if there is a wedging of the catheter. And of course, the pullback cutoff is 0.8. But the problem is that most of the times you may not get a simple, straightforward bifurcation like this, where you can put a wire down the circ or the LAD and get the true FFR. The problem comes when you have lesions like these, where you have a tandem lesion in the LAD. So the middle line probably can give you a possible false positive result. We don't know whether the left main is significant or not. And the one in the circumflex and just proximal to the distal stenosis will give you a false negative result. So how do we solve this quandary? It's very simple. What you see on the first is the true FFR. The second is an apparent FFR because that's not the true FFR because the LAD lesion is influencing the FFR in the circumflex, and then you get a composite FFR on the LAD. That's more than 0.65, less than 0.65. So if your composite FFR, epicardial, is less than 0.6, then your apparent FFR is significant. So if your lower epicardial FFR goes in favor of that, your apparent FFR is also significant, which you measure in the circumflex. And the other problem that occurs is in CTO lesions. Because of the CTO, the large area supplies the CTO, you may get false positive FFRs into the larger vessel. But of course, if you get a positive FFR in the donor vessel, then obviously it is significant. Now the most important part of the talk is impact of routine invasive physiology. How has it changed our practice? This was seen in Syntax 2, where they used physiology in 98% of patients and Ibis in 84%. 73% of the lesions are assessed without adenosine. And it made marked simplification of PCI. 46% of three vessel disease were downgraded to 2 vessel or 1 vessel. So obviously what was high risk for surgery, high risk for PCI, ended up undergoing PCI if necessary. So this was a good thing. And which is clearly seen in the MACE results, MACC results, which shows that Syntax 2 PCI was doing equally well to the Syntax CABG. That's because of the reclassification of the disease and avoiding unnecessary stenting. Coming to acute coronary syndrome, that's always a problem. In acute coronary syndrome, FFR can change rapidly, IFR remains the same. The problem is what do we do? But this study clearly told us that physiology-based deferral in ACS is inferior to angio-guided PCI. So don't do FFRs of non-culprit lesions during the acute event, because that can give you a false result and the outcomes are worse because of urgent revascularization is more in such patients. If at all you want to do a FFR or something, the minimum days recommended by ECI, the European Society of Cardiology, is 5 days after ACS. Or you go up and stent whatever you think is significant. Post-PCI FFR, very, very important. Only 22% measure it. There are no guidelines, and these are the reasons. There's incomplete stent expansions, stent malopposition, geographical miss. It's very important to do them because this clearly showed that if you don't have a satisfactory FFR, it's going to be a bigger maze. So post-PCI FFR is very, very important. The key message here is lower the post-PCI FFR, higher the maze. And if you have a low FFR, please do guiding, imaging to see what is the problem. Is the problem in the stent, distal edge, geographical miss? Here, imaging will help you. So we should start thinking about FFR as a tool to understand and evaluate our job after stenting. And now comes the newer innovations. We are having diagnostic image-based FFRs. By angiography, you can get an FFR without putting a wire, and it correlates well with the invasive one. Even after post-plasty, FFR invasive and angio seem to be correlating. In fact, you have virtual revascularization. So if you have a lesion and you put the software, it will tell you the predicted FFR after stenting, which is 0.95. And if you stent, and this found it to be 0.93. So this is the future. And of course, once this is perfected and comes here, FFR CT, it will be superior to all methods to date. That's my 10th commandment. And it correlates well with the invasive FFR. And this will be the future, which was a trial designed like this. So if you have a coronary CT angiography, if you have high risk anatomy, you clearly go for invasive coronary angiography. If you have low risk anatomy, go straight on optimal medical therapy. Now comes to the intermediate, you do the CT FFR. If it is less than 0.75, go for invasive coronary angiography. If it is 0.76 to 0.8, go for optimal medical therapy, 3 months follow-up, and then go by symptoms. If it is greater than 0.8, again go by optimal medical therapy. Thank you very much.
Thank you, Harish, for finishing all the 10 commandments, 10 minutes, and an excellent job done, I think. And we can have some discussion now, or any questions?
Sushil, do you regularly do post-PCI FFRs also after you do the pre-ones?
No, we generally don't, I'll be honest with you. We do a lot of FFR, a lot of IFR now for lesion assessment. But post-PCI FFR, not as much. It's resource utilization. We tend to use, if I'm going to do the intervention, I tend to use Ibis or OCT. So I do the assessment with imaging after, make the decision about whether to intervene, but I don't use the IFR or FFR to assess whether the intervention was adequate. I use the imaging. But yeah.
Yeah, well, just one comment. I totally agree that we should use physiology much more than we are using, because worldwide the penetration of physiology is around 6–10% of all the PCIs done worldwide. One of the limitations to use physiology after stenting is that the fact, if you consider that before stenting, the, let's say, accuracy of this FFR or IFR is around 98 to 99%. After stenting is around 67, 70% according to FAME 2 sub-study. Is slightly more than flipping a coin in terms of prediction of events. And this is probably one of the main limitations. We should try to find out why this accuracy is so low compared to before stenting. We don't know yet. This is probably one of the main reasons why it's not so used.
Yeah, because whenever there is no lesion, then probably the importance of assessment becomes less. Because sometimes where it is useful post-procedure is when you stent it across, where side branch gets pinched, you tend to work with an angiographic picture, but many times if you do an FFR there, people say it comes negative, and patients do all right there. That is one place I think where FFR has some role post-procedure. But if you have no such side branch compromise, doing alone, there are some studies to show that if it is more than 0.95, it's good. But as Lucas said, it is of less importance post-procedure compared to pre. Thank you very much.
One quick question. I know we're running late, but one quick question. Most of my coronaries are in the setting of valve disease. In the setting of aortic stenosis and hypertrophy, thick hearts.
Yeah, then you may not get it.
What are the challenges, and what do you feel about using FFR or IFR in the setting of aortic stenosis, LV hypertrophy? Yeah.
Probably you're not going to estimate it properly. I have not come across that. What do you do normally? I wouldn't know much what to do about that. If you have a patient like aortic stenosis.
No, basically LVH, how it influences the FFR.
That will influence the...
Yeah, because high filling pressures, LV, EDP.
So do you use imaging there, or what? How do you all decide?
We tend to use more imaging, but there is some people have looked at some data saying that maybe it's reasonable to use, but I think the cut points may be different, but I think we need more data on that. I think you have to be cautious in the setting of valve disease or severe hypertrophy about using this physiology. Great, thank you very much.
Yeah.
Thank you. I think we have interesting now guest lecture of sirolimus coated balloon. I think Concept Medical, which has made one of the first sirolimus eluting drug coated balloons. Very excited to work with this, especially when you have disease with small vessels, diffuse disease which tends to happen in our country. Let us hear more about it from Lucas. He has maximum experience with this, and let us hear and clear our doubts on this newer sirolimus coated balloon, which is actually called as Magic Touch.
Well, first of all, thanks for this kind invitation. I have to say that every time I come to visit your beautiful country, I feel the hospitality and friendship, so it's always a great pleasure. It's also a pleasure to talk about this new technology that actually is not really new for me, because in Europe we started to use this kind of technology more than 3 years ago, but it's probably something new. It has been nicely shown during the first presentation of this session that actually more than 40 years ago, actually the story of balloon PTCA started with the very first procedures that we had seen. And then we observed the revolution of the bare metal stent and then a drug-eluting stent. All these revolutions were actually aimed at solving the problems related to the previous generation of the job we're doing. And then the last generation will talk about is the drug-eluting balloon concept, which is actually related to the idea of treating the artery without leaving anything behind. But also, I would like to summarize what are the hypothetical merits of DCB technology. There's no metal. So we are treating the atherosclerosis, actually delivering the drug without leaving any permanent prosthesis inside the artery. And actually, there is also potential in reducing the duration of dual antiplatelet therapy. I say potential because, of course, it must be demonstrated before advocating the implementation of a new strategy, basically different from what the guidelines say. But also navigability, and there is a question mark, because if you have experienced some of this technology, particularly the first and second generation, you may have experienced that these devices were not really navigable and trackable, but now, current generation actually have been improved significantly compared to the previous generation. And also, there's no more polymer. And as you know, there are some hypotheses actually related to the possibility of increasing inflammation by the presence of the polymer. And I have to say that nowadays you can basically summarize the indication of DCB into these two big groups. The very first one is the in-stent stenosis. I can talk to you about the guidelines, particularly the guidelines in Europe, where the treatment of in-stent stenosis is not so clear. Because even the guidelines actually say that you can either use a new DES, possibly a different drug, or you can even use a drug called the balloon with the idea of not putting other metal inside the metal. Of course, I'm not going to go through all this literature because, of course, this is not the point. But the point is just to show you that according to this possible indication, there is a lot of research behind. The small vessel is another indication because, I can confirm that particularly in Europe, there is a tendency, which I actually agree, there is a tendency not to use metal, DES, for small vessel disease, but actually it's a proper definition. What is the definition of small vessel? Small vessel, at least according to the literature I'm talking about, is a vessel with a size not larger than 2.5 in terms of caliber, of course. And again, I'm not going to go through all these numbers, it's just to show you that there is a lot of research behind the concept of DCB for small vessel disease. What about bifurcation? Well, there is also another tendency, at least in Europe, is we all know that it's important to do the kissing balloon to keep up open the struts for the ostium of the branch. But there are some cases, and actually I agree with this opportunity, in which you can use the drug-coated balloon instead of a normal balloon, particularly when there is some disease, not a very significant disease, and of course I'm not going to talk about one stent strategy, two stent strategy. Nevertheless, the idea is to provide a delivery of the drug using the balloon for the kissing balloon for the side branch. And I have to say that according to all this literature, this is a strategy that works very well for our patients. But you need to remember that the first generation, as well as the second and third generation of balloons, they were all using paclitaxel. And if you remember about the recent happening about the FDA for paclitaxel, you may actually immediately understand that probably the paclitaxel is not the right drug, although the majority of the companies, the majority of the balloons have been done with paclitaxel. But I'm now happy to show you there is another possibility nowadays. The sirolimus is actually the drug used for almost all the drug-eluting stents we are using nowadays. And there is a reason why. The reason is actually the wider therapeutic range of sirolimus before reaching the level of toxicity. But also the safety margin, which is really linked to the safety of this drug, which is 10,000-fold as compared to the safety margin of the paclitaxel. And this is also the reason behind this technology. This balloon I started to use more than 3 years ago is actually the very first balloon, and it's produced here in India, actually with a sirolimus formulation, delivering sirolimus formulation in a encapsulation of sub-micron size sirolimus into highly biocompatible drug-carrying phospholipid. Without actually going into all these details, this is the very first technology using this formulation of sirolimus in order to address the possible toxicity of the paclitaxel. And I'm actually happy to show you what are the preliminary data we can talk about. This is the very first study done with this new technology. And actually it is a study done almost 4 or 5 years ago. It was a registry, a small registry actually, with a primary endpoint of MACE as a composite of cardiac death, target vessel myocardial infarction, and target lesion or vessel vascularization at 6 months. The secondary endpoint, of course, was still MACE, but at 1 year. The population was actually 450 patients, but with some subgroups we were talking about in a minute. And if you look at the population, of course, observed as being done in the majority of the cases in male patients. But if you immediately look at the percentage of patients with diabetes, you immediately understand that there's a very high percentage of this patient. And diabetes sometimes, well, very often means small vessel disease, diffuse disease, all those conditions in which you don't like to put a lot of stents. These are actually the lesion and procedural details. As you can see, the device of patient 1.2 with a 0.4 events of vessel dissection, which is one of the main concerns using the drug-coated balloon technology. But look at the data. This is the primary endpoint, but also 12 and 24 months. As you can see here in this diagram, the rate of MACE was steadily really low in this population, again, 450 patients. But also, if you look at the TLR and TVR, but also target vessel MI and cardiac death, you will immediately understand that what is the safety of this procedure, but also the effectiveness. This is also the clinical evidence in complex cohorts at 1 year. As you can see, this trial, this registry was not powered for subgroups evaluation, but at least it was able to generate some hypotheses. And in particular, if you look at the ISR patients, but also ACS or DES ISR, which is uncommon, but is real, you can see that the percentage of the cumulative events is really low at 1 year. This is actually the future, because we are collecting data in a very large population of patients. This is a global registry based in several countries, I will show you in a second, with the objective to observe and evaluate the performance of a sirolimus-eluting drug-coated balloon for the treatment of any type of coronary lesion, including native vessel disease and in-stent stenosis. This design is really relatively easy because it's prospective, multi-center, spontaneous clinical registry with external validation of data input, centralized clinical event assessment, and it's going to be a real-world, all-comers patient, consecutive enrollment, aiming at a target 2,000 patients in 45 European and Asiatic sites. This is actually the breakdown. There are some patients enrolled actually throughout this part of the world. This is also the situation, and I'm proud to say that I'm still the top enroller since the beginning with more than 100. Well, actually, this number is not updated because it's far beyond 200. But just for the sake of clarity, this is the breakdown of the enrollment. And the few data will be presented at TCT, next TCT in San Francisco. So let me conclude. The drug-eluting balloon is a revival of a new technology because we all started with the POBA. But the outstanding feature of this technology and its ability to dilate stenosis, along with the effective transfer of anti-proliferative drug, nothing behind left, neither metal nor polymer. The magic touch technology, which is an Indian technology, elutes sirolimus, hence assuring safety in CAD patients. The clinical studies of magic touch demonstrated promising rates of MACE in patients with ISR and small vessel up to 2 years. The studies also demonstrated excellent procedural success. And in Nanolute, the first trial, the clinical outcomes in complex patient cohorts are very encouraging and warrants the use of SCB in complex patients too. The Magic Touch sirolimus-coated balloon catheter will be assessed against the paclitaxel-coated balloon and drug-eluting stents in the upcoming randomized controlled trials, which is under evaluation at the FDA. Thanks for your attention.
No, so I think it's interesting. The question is, how do we get the data? You know, in the last slide, you said we're going back to a technology we know. So what are the subsets where this is the right technology? Is it just small vessels? Is it bifurcation? And, you know, as we saw with bioabsorbable stents, there's different techniques that have to be used. It's not just the same. Is there a technique here? Do you have to prepare the lesion? Are there lesions that you avoid, like calcified lesions? So you have to teach a new skill set again.
The main concept behind the use of DCBs, any DCBs, not just this one, is that the DCB must be taken as a delivery system. It's actually a carrier, because it must be used only to deliver the drug in place. But you need to prepare the lesion. You need to achieve the relief of stenosis before with all the other techniques, using non-compliant balloon, scoring balloon, whatever you want to do. But you need to consider that a DCB is just a carrier. It's not a balloon to dilate the lesion, because it's not made for this. It's made to deliver the drug where it's needed. So in other words, all the things that you have to do for the lesion preparation before stenting must be done, as well as, or even more, for DCB delivery. That's the thing. Regardless, the indication can be small vessel disease, can be ISR, can be bifurcation. But this is not the problem. The problem is the DCB is the very last thing that you use for your patient after all the preparation that you must do.
I think if you come across a dissection which is significant, where you feel like putting a stent, you prefer putting a, nowadays bare metal is not available also,
but you are comfortable putting another drug-eluting stent after delivering the drug with the balloon?
Yes. I mean, I have to say, depending on the dissection, because if the dissection is a flow limiting, it's a major, let's say major dissection. If it's a major dissection, I don't have data to show, honestly, but still I believe that nowadays we cannot leave a major dissection alone. We need to put a stent to seal the dissection. And honestly, I'm not worried about the possible drug toxicity because, as I said before, particularly with the sirolimus, the range of toxicity is so far away compared to the drug that is actually delivered. I don't think it's going to be a problem at all. With paclitaxel, well, I don't have data, but with sirolimus, I'm pretty sure it's not going to be an issue.
A lot of negative data came with paclitaxel regarding the malignancy aspects, and what are your thoughts about it?
Well, that's hard to say, honestly. It's really hard to say. But we'll see, because some of this answer will come with these new studies ongoing. We'll see.
Okay.
Anything? We have used this balloon. It is quite good otherwise. But only thing is when there is a proximal LAD or something like that, in that situation, you are always think that the stent should be put. But otherwise, definitely in those cases where ISR is after stent deployment of circumflex origin or something like that, in that situation, this balloon dilatation with drug coating is the best. We have done few cases where ISR becomes after this stent, and then you open the circumflex with this coating. But definitely for bifurcation lesions, as a single strategy, this will evolve, I think, as a good strategy.
LCX ostium is a difficult animal to treat. I think there are some cases which are shown in the coming days. You selected some cases where you treat LCX ostium with this newer type of balloon. Any thoughts? You are telling something, Sushil?
No, I guess the question is, from your perspective, I mean, I know the trials are ongoing. What do you see the role of this technology? I mean, we'll also, as a primary therapy, clearly for ISR it makes sense. But how do you envision? Because it's available here. So how do you envision people utilizing it in their practice?
Well, I have to say that I'm really interested in the concept of leaving nothing behind, and particularly in those occasions. Let's say, for example, that some of our procedures are done to the second marginal, second diagonal, third diagonal. In this, let's say, subset of anatomies, you don't need to put a stent because the advantage of the stent over the POBA, over the simple dilation, is still far to be demonstrated. I'm not talking about the left main, proximal AD, proximal circle. I'm not talking about that. I'm talking about small vessel or ISR. And I honestly believe that, waiting for the data, we may have the possibility to show that we don't need to put a stent. We need to deliver the drug, leaving nothing behind. And this is my vision, because honestly, I don't feel good when I have to put a stent in the third marginal 225 stent. Right. What's the point? Right. If you just deliver the balloon, you deliver the drug, you open up the flow, that's what you have to do. This is what you have to do.
What is your antiplatelet strategy after this? If you don't stent and it's just a drug-eluting balloon?
Well, honestly, I try not to put stent, let's say, smaller than 2.5. I try as much as possible not to put those kind of stents. And I have to say, it is also a matter of approach, a matter of culture, because for example, I know that colleagues from the Far East, in Japan or in Korea, they put a lot of stents, 2.25, even 2.0. I never put a 2.0 stent, honestly. But still, I don't have the data to show that I'm right. Actually, going back to your question, this is my vision. My vision is not to put small stents, because we know that in terms of late loss, target lesion failure, TFR, TLR, and all the possible complications related to the stent, small vessel is the main predictor.
I think as of now, instant stenosis, where we don't want another layer, that is definite indication. Second thing is where you have small, especially in India, we do see a lot of diffuse disease in diabetic patients, where the one stent cannot do the job. But always this worry of edge dissections will be there. Yeah. But as long as there is no major flow limiting dissection, I think we can leave it. I think with this, I think we can have more discussion with him during dinner time with Lucas. Thank you, sir. You can join us here back. And we'll go on to an interesting lecture, Left Main PCI Do's and Don'ts with Dr. Vijay Bang. A senior cardiologist from Mumbai, always ready to help in any of the meetings. He himself conducts one.
and let us hear from him do's and do nots. Nowadays, a lot of youngsters also started doing left main PCIs. The role of imaging is always highlighted, even during live case, and it's almost mandatory to take help of imaging when doing. Let us hear more of it from senior professor, Professor Dr. Vijay Bang.
Yeah.
He has credit of training a lot of youngsters about, he conducts meetings, about 200 of his fellows attend. That's to his credit of teaching.
Thank you very much for this opportunity, Srinivas. Really grateful for that. And we all know that the left main is something which is coming up very popularly. Everybody wants to do a left main. It's better to understand at this stage what is to do, what is not to be done in the left main and what is to be done. There are two things, strategy and the technique. Incidence of the left main is 5 to 7%, and most of it is distal. It has become a staple for the cheap operator. Cheap operator, this is a staple left main lesion. Particularly the left main lesion with the low EF, they take the hemodynamic support with the impeller, and that works out a safe procedure for them. A lot of hard team discussion is involved in deciding those complex cases which are particularly in intermediate syntax core group. And imaging, of course, is a tool further, and FFR has to be also used in these cases wherever you have a borderline lesion assessing the left main severity. Now, question is what to do and what not to do. The earlier when we started, in 2010, the indication for the left main PCI has begun after the Excel and the Nobel trial. And they progressed further, and currently, for syntax score less than 22, it is as good as the surgery. So surgery has no added benefit in that class particularly. So surgical hard team approach may not be necessary in the syntax score less than 22 in left main lesion. Whereas syntax score more than 23 to 32, you do need a hard team approach to decide what is best between the two. And there is a lot of discussion in that strategy and technique. The class 3 we know is always a bypass surgery most of the time, unless STS score is very high or Euro score is more than 7.5. Surgical mortality is very high. Those patients definitely have to go for the complex PCI with a limited revascularization. There is NCADR data which is from America. From 2009 to 16, they have done almost 33.5 lakhs total PCI. Out of that, only 1% is left main PCI. And the numbers are increasing. In 2009, it was 0.9%, whereas in 16, 1.3%. The Asia specific, this is a very interesting data that we have. 50 centers where data were recruited in left main PCI, China, India, Indonesia, Japan, Malaysia, South Korea, Taiwan, and Thailand. And almost 5,800 cases were analyzed. 50% of them were PCI, 40% CABG, and 10% medical treatment. Out of that, if you see the MACI rate was the highest in the medical treatment group. So medical treatment is certainly not the option for left main lesions. The best is either the PCI or the CABG. Between the two, the MES rate is obviously more in the PCI group and requiring more target vessel revascularization. Whereas mortality is slightly more in the CABG group clearly, and which is p-value is significant, is statistically significant. So analyzing these data, they have analyzed that in PCI group, particularly when age is more than 65, patient has a CRF and prior history of heart failure, they have a higher MACI rate, and if they have a low EF, then they have a higher death rate. Whereas in CABG, it is moderate. So those patients with a severe complex disease, they definitely benefit by CABG than the PCI, and medical treatment is out, not suitable for severe lesion, left main lesion of any type. What not to do in PCI, in left main lesion, one is if you have a EF which is low, less than 30% with eGFR of 40 ml per minute, these cases should be avoided by PCI because they have a very high MACI rate and death rate, so it should be avoided. Heavy calcification requiring rotablator, those cases also should be avoided. And of course, those patients who cannot tolerate the antiplatelet agents, and those patients should not be tried for the left main PCI. The CABG is obviously the option for patients with CAD along with the concomitant valvular heart disease or mechanical complication during ACS like the rupture, septal rupture, intravascular septal rupture or the mitral regurgitation. And a diabetic patient, of course, reduced EF and multivessel disease. In ACS, it's very important to draw an algorithm, what to do and what not to do, in which patient we should do PCI. Those patients with a cardiogenic shock and hemodynamically unstable, they are very suitable for PCI, not suitable for CABG. Only stable hemodynamical patients are suitable for urgent CABG if they have unfavorable anatomy to do PCI. And non-culprit lesion also is important if patient to do it by PCI, a patient has a cardiogenic shock. So this is the area which is very controversial, what not to do and what not to do. What to do is best is left to the expert who's performing the angioplasty at that time. So in technique, what we should do is, the idea is to have an optimal rheology, means the flow pattern, which should be very optimal, and wall stress should not be created. Otherwise, if you have a wall stress, restenosis rate is very high. The stent should be well opposed and easy access to the side branch if you are doing a left main bifurcation lesion or provisional stenting. When you do an angio and you see an ostial lesion, it may be a pseudo-ostial lesion, ostial bias, maybe spasm, intracoronary nitroglycerin. Usually you can see a relief the spasm by Ibis, you can see the results. So be careful when you have an ostial lesion. Always first try intracoronary nitrate, maybe a spasm. So whereas when you have a lesion, the concentric lesion in the left main ostium can be easily tackled with the stent, and eccentric lesion also can be tackled. But the lesion which is having a long ostial lip protruding into the left sinus, that is one which should not be attempted by stenting because it will create a lot of overhang into the stent overhang into the sinus. So this is the Ibis picture which clearly detects. So ostial lesion, if we do Ibis, that is a better. At least we can detect that if it's large leap of the atheroma hanging into the left sinus, that case should not be done because too much overhang of the stent may create an issue. When you have an ostial lesion, best view is, as we discussed earlier, cranial view should be done for all the cases and APRAO view. I was talking when Dr. P.K. Goyal was doing a case, I was talking of angle, left main vessel angle, which is left main to LAD. The angle is, if it is higher the angle, the provisional stent results are better. If angle is low, provisional stent results are a little different, and they're statistically significant. Miss rate is higher. There's a study done of almost 300 patients followed up with the provisional stenting with the high angle, middle angle, and the lower angle. And we can see that high and middle angle do well. Event-free survival is very good. Whereas the lower angle have a very, very high event rate and indicating p-value of 0.041, indicating it's significantly different. That is what it's trying to show. If you have a wide angle, then you can see that the restenosis rate is low because of the low wall stress. created by the flow. If the angle is high between LM and LAD, the wall stress is high, and you can see a restenosis rate is higher. So is how imaging helps in most of the time when we do LFMN, because by imaging we can come to know whether there is a spiky carina or eyebrow sign positive. Those patients will not do well with the provisional stenting. Carina shift will lead to restenosis and the osteal compromise. That's why the side branch, when osteal compromise is there, you have to take care of do the FFR, and if FFR is negative, usually those patients do not require a second stent. Only a kissing balloon is fine. But along with the carina shift, if there is a plaque shift, those are likely to be a positive FFR and may require a stent. When you have a lesion in the Leftman which is ambiguous, where you are not very sure which part of the branch it is involving, then it is better to do a imaging and make it clear whether there is a problem or no problem. When you are doing a bifurcation stenting, one can see that if the angle is more than 70 degrees, T-stent is fine. But if you try to do a T-stent in the angle which is less than 70 degrees, you will leave an ostium without the stent. So, whereas the mini crush, which is now a popular technique, can be used for all the angles. When you have an angle the distal angle, the LAD and the circumflex angle more than 110 degrees, then T-stenting is the only option where, because you can see a crush technique, you can see Quillot, and you can see SKS. In all these three, the native carina, the neo carina is not opposing the native carina. That is leaving a gap between the two that becomes a source for nidus thrombus formation and higher mace rate. So this is the practical case which is demonstrated, and the most important Achilles heel of the Leftman bifurcation stenting is the restenosis of the circumflex artery, ostium particularly. So before you do a FKI, do a high pressure inflation at the circumflex ostium before doing a FKI. And when you do a bifurcation stenting, few things which are very important that you need to take care, and do's and don'ts are very sincerely followed here, that must be assessed properly, the plaque burden, the location of the plaque, the angle between the main branch and the side branch to decide what kind of stenting technique likely to be used. And no two bifurcations are identical. Imaging does help a great way to assess whether there is how much calcium is there. If the calcium is less than 270-degree arc of calcium, then cutting balloon is okay. So that also helps in deciding what kind of devices you are going to use. If it is more than 270-degree arc of calcium to up to 360-degree circumferential calcium, then rota is preferred. That is how the pre-procedure IVUS helps you in deciding whether cutting balloon or rota to be done in a given case. And optimization of the stent is very important because stent should be opposed, particularly in Leftman, in deciding the size of the Leftman and opposing the Leftman properly. Post-dilatation non-compliant balloon using a proper size of non-compliant balloon as per the Murray's law so that it appropriately fits in the size of the Leftman lesion. FFR is going to play an important role over a period of time. As we discussed that if that is a borderline lesion, then FFR should be measured both in LAD through wire across the LAD and circumflex and evaluate the composite FFR. So OCT also can be done in a situation, but except for the ostial Leftman lesion, OCT may be very challenging. And provisional stenting is very useful technique. Most of the patients undergo provisional stenting, almost 80 to 85%. whereas 15-20% may require a two-stent strategy where POT, repot, and FKI is very, very important. To decide the type of the technique that your simple lesion or complex lesion, apart from the length of the lesion in the side branch, that is less than 10 millimeter, you need to look at the other criteria which we often fail to look at. These are moderate to severe calcification, multiple lesions, LAD LCX bifurcation angle more than 70 degree, and main branch diameter more than 2.5 millimeter, the thrombus containing lesion. Out of the two, if out of the 6, 2 criteria are present, then it is better to go for two-stent strategy rather than make it a complex PCI. So start the procedure with the FFR and finish with the imaging. You can make a good clinical outcome in this patient.
Thank you.
So long-term results, if you go to see after the surveillance, provisional, very good result, hardly any stent thrombosis rate, less than 1%. The risk stenosis rate 6 to 10% like any other patient with a DS. And antiplatelet therapy for 1 year when you do a left main stenting. That is the classical. So this is the India conference which is going to come in October 17 to 20. And may I request you to save the date. Thank you very much for kind attention.
Thank you, sir. I think this discussion can go on further in further talk to follow. And then we have another left main session. Thank you. We'll have discussion later. We're slightly behind schedule. We have Gary Mitt's talk coming as a webcast. We have now another interesting talk. A very good friend and expert in bifurcation, optimizing PCI in my clinical practice. My 10 messages. We're very fortunate to have Dr. Miroslav Ferenc. We have involved in the original studies of EBC bifurcation, and always good friend. He had to come recently again when we requested. He agreed to come. Thank you very much, sir. Doctor, as you know, he's from University Heart Center, Freiburg, Germany, and he was involved in EBC. Let us hear more from him. And nowadays, optimizing PCI, the 10 most important things. We'll also hear about bifurcation from him tomorrow. Over to you, Dr. Ferenc. Thank you.
Hey, Dr. Kumar, ladies and gentlemen, namaste. Thank you so much for the invitation. And so, do we have picture?
Yeah.
Okay. Thank you for the invitation. I try to make some points sure. If you go with PCI, what is really important for doctors, especially if you are starting with PCI procedures. I'm coming from University Heart Center Freiburg Bad Krotzen. This is a southwest part of Germany, a very country area, country-like area definitely. And you see there are many top buildings here, big buildings, and if you just take a look to this gray building outside, so if you go inside, it looks really like very nice hotel. So the philosophy of this center based on, to try to get a very good medical expertise in combination with a nice hotel-like surroundings. Some people like it. That's why we have every year a bit more patients from around Germany. So you see here many hospitals who are working in networks with us. So finally we have together with Freiburg, so we're a University Heart Center and 2 locations. So we have around exactly 15 cath labs and 11 of them are in Bad Krotzen. So altogether we have around 5,000 PCIs a year. So that's a huge high volume center in Germany. So back to the basic principles, and you see there was a long list, but I will summarize this very clear. Before you start with complex PCI, of course you need to identify the right patients. You have to make correct indication for PCI. I think everybody of you knows can always something happen and you need you need some kind of justification. If something happened, then you are on the safer way. So the evidence of ischemia or prognostic value is a must, and so you can have patients with angina, you can have documented ischemia, and patients or vessels should be responsible for angina if possible. High quality coronary angio is essential, and I think a good start to PCI. To understand complex anatomy, you need really high quality coronary angio. Like this, you have a good guiding catheters, a good contrast filling, so you see very nice what the problem is. Another point is that many doctors see collaterals, and they believe, okay, if somebody has collaterals, then this could mean the patient has sufficient perfusion, but in reality it isn't. So only in 20% collaterals are sufficient for make sufficient collateral perfusion. So it means in 80% collaterals, we see collaterals, but they are not sufficient. Other important point, and this is really important to make high quality coronary angio, to see, or at least to try to see microchannels. So in histopathology we can see many channels, and this is especially in total chronic occlusion very important. If you have flow according to microchannels, you can cross this usually with soft polymer wires. And this is always very important to try to get complete revascularization. This is very clear point to get or to improve a patient's long-term survival. So there is enough data which support or make clear complete revascularization is beneficial for our patients. Good quality angio make possible to understand the lesion anatomy and complexity, and this is fundamental point. If you have such microchannels, so then if you see this in two different projections, then you can differentiate this is collateral bridge or it's really microchannel, whatever. Then you can go easygoing, or you can cross very easy with special CTO wires. Guiding catheters, another important point, and everybody of you, me including, I'm quite sure everybody of us has once a week or once a month situation. So we start to do procedure, and after 10 minutes, after a half hour, we see guiding position is really not good. We have to exchange everything. So optimal backup is one fundamental point. Usually the complexer lesion, the bigger, the larger guiding catheters. So we usually go for left main with 6 French, and we usually go with femoral, but of course you can go in man, you can use 7 French radial approach. If you see this one, you see you can very nice intubate the right coronary artery. However, if you start a CTO procedure, this will be really very difficult. So you need a backup catheter, guiding catheter. This is an Amplatz with side holes. Then you need micro catheter. Then you can start to be really successful. If you have problems with support, I think guiding extensions like Guideline or Gatezilla today very helpful, and you should have it in every cath-lab. In every larger cath-lab, such devices must be, because if you need, then they are very helpful. The right technique, having plan B, this is I think very important point, and few comments to this topic. So if we have bifurcation lesions, provisional sideburn stenting is this method, which is mostly recommended from the European Bifurcation Club. So we try to get bifurcation lesions with one stent, but however, according to the literature, we have in around something between 5 to 36%. They need to put one stent more. So double stenting is also needed. This is just example for provisional sideburn stenting. You stent the main branch, final kissing, that's it. But if you need two-stent strategy, we have few options. TN protrusion, culotte stenting, and dicky crush are most used techniques, at least in Europe. And you see here schematic how we do this. Modified T-stenting tap is easy-going approach. You stent the main branch, and then, if needed, you go with one stent more to the side branch. The problem is sometimes you can have gap or protrusion is too strong. Culotte stenting technique is a bit more difficult, more steps, and if you perform double kiss and crush stenting, then you have to perform around 9 or 10, 11 different steps, and this is really, from my perspective, most difficult technical approach. And which limitations do we have during PCI and bifurcation lesions? You see, if you have a large angle, this is contraindication for culotte. If you have small angle and large side branch, here is quite difficult to perform tap, because then you have here quite a large neocarina, metal neocarina. Here will be maybe culotte, very good. And sometimes there are clinical situations, it's difficult, sometimes not really possible to perform culotte or tap. And this is, at least in Germany, at least in our high volume center, ideal option to perform dicky crush. So you see, according to the anatomy, we adapt our technical approach. But however, we start to treat patients with single stenting approach. According to the CTO procedures, you see, we have two options, practically three options: antegrade, and if you use tapered tip wires, if you use microcatheter, if you use parallel wire technique, and of course contralateral injection, you will be able today, nowadays, in around 70% of cases to be successful using antegrade approach. And in 30%, 20-30%, you need then retrograde approach. Of course, expertise is an extremely important topic in CTO, and sometimes you need cross-pose re-entry techniques. So once again, I was many times in India, and what I saw, many doctors in India, they doesn't take care regarding X-ray problems. This is a really big problem. So in our center, we always covered patients with X-ray cover, so we have protection, and this reduce X-ray dose for the operator in around 70 to 80%. So please try to do this also in your cath lab. So there are different wires, just to shown here. You escalate from soft, intermediate, and to stiff wires. You start with Fielder, maybe Ultimate or Gaia Second, and then finally you end with Gaia Third or Confianza Pro. And yeah, you can perform really many cases successful PCI using antegrade approach. You need good skills, you need good wires, you need good visualization, and then you can be successful. Very important point is, if you have experience with Gaia, you can make practically from Confianza Pro or Conquest Pro Gaia-like wire with some band here. and verification of distal wire position is in the CTO business a must. You see, if you go with the wire, then you can just make sure your wire distally is in the vessel. Of course, you have to change techniques, strategy when initial plan fails. And what is the main problem in PCI? It's a calcium. It's a calcium. Calcified lesions are #1 problem, and we are now trying to make some solutions. So you need really low profile balloons. Which low profile balloon we use in our cath lab? I use usually Katsuki. This is a Japanese balloon, very low profile, crossing practically in 99% of all lesions. Of course, rotablation sometimes is needed. Sometimes you need OPN balloons, very high pressure balloons, which are now available in India. And of course, cutting balloons and shockwave balloons are additional tools to manage this. Here, just to show you, we can, if we have such ring calcification in the lesion, we are not able to open this lesion with balloon. So we just cross with the wire, maybe with balloon, but balloon doesn't open. So you have to ablate and make the cap a bit thinner. Then you can you can crash the calcium crack. So everybody knows rotablation, principle of rotablation. We use now more and more, and we use in Europe also lithoplasty, which is just shown here, catheter, which is a bit bulky, and this is a problem. If you have really calcified lesions and subtotal lesions, you have to predilate or even rotablate first before you can cross with this device. So this is a helpful thing, but not in every case possible to use. And of course, there are many options. You have to learn to use microcatheters. They are very helpful, especially in CTO. And you should have, for bifurcations, it's a must from my perspective, you have to have supercross microcatheter. You can have here angle of up to 120%. So then you can go even, you can cross easy going such lesions. So it's only possible to go retrograde. So you can antegrade, no way, there is no chance. You can maybe make some modification of wires, and this is technique, Swan neck technique. You can use this, you can try with normal wire, not possible. You go with Swan neck, you go back with the wire, and if you remove the wire back, the tip is going more and more inside. This is the trick. And then finally, you can manage such bifurcations very nicely with double stenting. And sometimes you have such anatomy like this. Don't worry, you still can manage this. There's some aneurysm, and how to tackle this. Sometimes you have to go really with a loop, with a soft wire, and then you can manage this again with double stenting. Ibis is a must in complex PCI, so we use it this not in 100% of cases, but if needed, definitely. Don't forget to know and to treat if you are too long with a procedure, if X-ray dose and contrast medium dose is too high, so you can split procedures, don't do too much. And to recognize and treat early complications is, I think, also essential. So this is some, I think, very nice picture from Germany. Probably in India you don't see this in many times. The patients with many stents, with pacemaker, clip, occluder, and TAVI. So this is the future of interventional cardiology. Thank you so much.
Thank you, sir, for covering all aspects of interventional cardiology, ending with that sort of what future possibilities. We are also just reaching there. Our patients are also aging. Nowadays, they come with a lot of procedures. I think we are slightly behind and we need to go to webcast. He'll be with us again tomorrow. We will have very quick questions and clarifications with him. And there is a slight change I mentioned as Dr. Lucas will be leaving tonight. I requested Dr. Shivkumar, thank you Shivkumar for agreeing for that. And instead of him, you have his next presentation of Dr. Luca coming on his aspects of newer trial which is presenting. We'll have that debate between Ibis versus OCT. Dr. Vitisha is slightly delayed. We'll have it after the Gary Metz lecture and live cases, maybe around 9 o'clock. Over to Dr. Luca.
Yes, that one. All right, thank you again for this kind of invitation, but mainly for now the opportunity to talk about this technology. Again, I'm talking about another technology actually produced here in India. And some of you can be already very familiar with this kind of stent. Actually, it has been used in the very first live case today. And I'm talking about the Abluminous DES Plus, which is basically, as I already said in the title, is a DES Plus DCB strategy. Well, if you just come back to the scenario, this is the prevalence of diabetes, but also the outlook in terms of the next future, because I'm talking about 2040. I mean, it has been actually calculated that all around the world, in 2040, we will have more than 600 million patients affected by diabetes. And this is just a single number that I want to tell you to express what is the magnitude of this phenomenon. And also, if you look at the diabetes plus, this interaction with the heart disease, you may immediately understand what is, again, the magnitude of the problem, because definitely a person affected by diabetes has 2-3 times higher risk for heart disease, but also he has 60% chance of dying from heart disease. So the diabetes is actually a real big problem, and I understand that mainly here in Asia is probably something related to almost half of the population. So, what is the point of talking about diabetes nowadays in our current PCI practice? And well, actually, the reason is exactly there. If you look at this figure, you may immediately understand that from the comparison of a everolimus-eluting stent against the previous generation of stents, the paclitaxel, you will see that when the conversation is around patient without diabetes, there is a strong advantage of everolimus-eluting stent versus paclitaxel-eluting stent. And this is true for the combined endpoint, but if you look at the patients with diabetes, you will see there's no more differences, meaning that the performance of the last generation everolimus-eluting stent family against the paclitaxel-eluting stents is exactly the same. So we made a very big step ahead when talking about the general population, but talking about diabetes, there is still a suboptimal results, or at least comparable to the previous generation of stents. But if you look at the ischemic TLR or at the combined endpoint, you will see that actually the situation is exactly the same. When we focus our attention on patients without diabetes, again, everolimus-eluting stent family is much better compared to paclitaxel-eluting stent families. But this is not true when we focus our attention on diabetes. So, actually, talking about the limitation of current DES, we may take a lot of time, but I would like to summarize what is happening actually really true. The delayed vessel healing to the slow endothelialization and the high inflammatory response may lead to higher risk of stent thrombosis and may lead to higher risk of in-stent thrombosis, actually leading to cardiac death, target vessel MI, or a PCI. So what is the point of talking about this when you have these technologies? Well, the Abluminous DES Plus idea is actually able to tackle this problem with a very smart solution, I would say. The Abluminous DES Plus is a cobalt chromium stent system designed for diabetic patients and approved in Europe for diabetic patients and acute MI. The abluminous is designed to treat diabetic patients with the so-called Envision technology. I'm not going to go through all these details, but I just want to tell that this device is characterized by the abluminal coating. So the drug is only against the arterial wall where it's needed, but also is able to address the problem of focal restenosis because both the stent as well as the exposed parts of the balloon are coated with to increase the surface area. But if you look at the very last thing on the bottom right, it's also be able to address the edge restenosis because 0.5 millimeter from the proximal and distal ends of the stents are coated. And you know how much is important to address the problem of edge restenosis because the highest rate of restenosis is just at the edges. And this is just a figure to show that what is the meaning of combining the technology of a DES plus a DCB. The thing is that the polymer as well as the drug is actually present on the surface of the DES, but also on the surface of the balloon, meaning that while inflating the balloon, there is actually a burst of drug delivered at the moment of the delivery of the DES, and then a controlled release of the drug lasting around 1 month. This is the clinical program. I will be talking briefly about all this trial, and I have to say that the very first one is actually the ENABLE-1 study, which was prospective, single-center, non-randomized controlled trials done in India. It was a first-in-man clinical evaluation, and as you know, the first-in-man evaluation is usually made on the basis of a few patients in order to understand the safety mainly, and then the efficacy. So the ENABLE-1 study was a first-in-man clinical evaluation of a abluminous DES Plus drug-eluting stent for assessment of safety and efficacy in treatment of CAD. 40 patients with angiographic follow-up. The design was relatively easy, prospective, single-center, non-randomized, in a real-world scenario, with a primary endpoint of in-stent late lumen loss at 6 months, evaluated by means of QCA, and some actually a full list of secondary endpoints, but clinical endpoints, which are not powered for that. But anyway, these are what they have found. The abluminous DES Plus has been implanted in 40 patients with a mean age of 54. If you look at the first left part of this, the diapo, you will see that diabetes mellitus, it was again in a percentage over 42% of the cases. There is a nice representation of all the possible indication, LAD, LCX, RCA, and all the type of different lesion class according to American College, American Heart Association classification. And actually these are the results. As I said, 6 months QCA, the late lumen loss in segment was in the range of 0.17, plus minus 0.29. And the late lumen loss in stent was in the range of 0.22, plus minus 0.3. The ENABLE-E registry is actually the step number 2 in the clinical program. This is a post-market registry of luminous DES Plus, and it's actually still ongoing in terms of follow-ups. The objective was to evaluate the safety and efficacy of the luminous DES Plus in an all-comers population with minimal exclusion criteria. Study design was multi-center, prospective, all-comers, ambulatory visits or telephone call at 1 month, 9 months, 1 year, and then yearly up to 5 years, with the primary endpoint of major adverse cardiovascular events, composite of cardiac death, target vessel MI, target lesion, vessel revascularization at 1 year. And these are the patients. So, diabetes, again, over 1/3 of the population was diabetic. 2,500 patients enrolled, and up to 90% of the patients completed 2 years follow-up. This is the breakdown of the MACE at 1 year, but also in yellow at 2 years. As you can see, there is, well, let's say, surprisingly low rate of MACE as well at 1 year as well as at 2 years. And you can say exactly the same thing for the cardiac death rate, TVMI, TLR, TVR. This is in the overall population. But we are talking about diabetes now. And let's see if there is some signal here. This evaluation has been done comparing the diabetic population versus the non-diabetic population. The diabetic population was actually not just a subgroup, considering it was, well, concerning almost 900 patients. And if you look at the breakdown of the results, you will see that there is no difference in terms of MACE in patients with diabetes versus patients without diabetes. Of course, these numbers are numerically higher, which is absolutely conceivable. Nevertheless, in terms of statistics, there's no difference. As well as there's no difference for the cardiac death, TVMI, TLR, TVR, but also for stent thrombosis. But what about this? Well, this is actually just a formal ideal comparison against what we know from the literature. The performance goal is actually based on DES trials, meta-analysis, including diabetes, DRAV-LDM, Sirius DM, Taxus, Scorpius, and Endeavour-Pool diabetes mellitus. And as you can see, the cumulative events is around 14%, while, as I showed before, for diabetic patients in this registry, it was in the range of 3.8. So, of course, we are not making any statistics here, because this is just a comparison against the historical data. Nevertheless, if you look at this, of course, you may think about a signal. And this is actually the signal that we are talking about. If you look at the results in patients with acute myocardial infarction against those without acute myocardial infarction, the situation is actually the same. Because in terms of MACE rate, cardiac death, but also TVMI, TLR, TVR, there's no statistical difference, meaning that the performance of this device is actually the same, or at least comparable, regardless the presence of diabetes, regardless the presence of acute myocardial infarction. The technical registry is the further step. Actually, this is a step I am proud to be the principal investigator worldwide. The objective is the capture clinical data of a voluminous sirolimus-eluting stent in real-world all-comer patient with diabetes. So this is registry coming from the signal observed in the previous one. The study design is a prospective observational multi-center worldwide. All the patients will be followed up for 5 years. The primary endpoint is a common one because it is a composite of target lesion failure, meaning that it's cardiac death plus target vessel MI and clinically indicated cardiac lesion revascularization within 12 months, and then a full list of secondary endpoint. This is a situation as of now where the majority of the centers in India, of course, some centers open in India and then in the rest of Europe, and just one in Malaysia, but much more are to come. And this is a situation of the enrollment, not really updated, but this is kind of, where more than 363 patients are already enrolled. I do remember that the target is 5,000 patients. What is this? This is the next step again, the ability randomized control trials. It's going to be a randomized clinical trial of a voluminous DES plus versus a everolimus-eluting DES for percutaneous coronary intervention. This is an investigator-initiated pilot study. And personally, I have to say, this is actually what we need to do in terms of assessing what is the reality of the signal. The objective is to compare the angiographic and clinical performance of voluminous DES plus versus the everolimus-eluting DS in patients with diabetes. So again, we observe a signal, we are actually going too deep, this signal. The primary endpoint is the instant neointimal volume at 9 months, actually assessed by means of OCT. So in this pilot study, what we are going to measure is the interaction of this device with the arterial wall to see why we can explain this difference, particularly in patients with diabetes. It's going to be multi-center, 7 Italian sites. And 48 patients have been enrolled from those 8 sites. There is actually another study, which we will start probably end of this year, in October maybe, and it's going to be randomized controlled trials targeting diabetes, actually in US, Asia, and Europe. And it will be powered for superiority against the everolimus-eluting stent family. But this is actually just an anticipation, and probably at TCT we will know more about this. Thank you very much.
Thank you, Dr. Luca, for sharing your experiences with the newer concept of the stent. Hope it works well. In real world, deal among more types, we always want more better things for patients. Just planned with taxes in diabetic subsets before that it should do good, but it didn't happen. Hope this newer type of stent, LMS eluting stent, produces more better solutions for us, especially in diabetic individuals where we tend to get more little TLR. Thank you. I think Arimid is waiting for the live webcast to come. I think we will go straight to him. A lot of us time we have debates and discussions whether to purchase OCT, Ibis, and what we should invest on. I think there can be more better, none other than Dr. Garimitz to answer and share his thoughts with recent papers which are published on JACC and other things. I think all of us can see now and we hope to hear you with opening comments on this webcast from Dr. Sushil too.
Hi Gary, can you hear us or can you?
I can hear you very clearly, Sushil.
Well, we can hear and see you very clearly, so it's perfect.
Great.
So do you want to go straight for it? Perfect. Thank you.
Okay. So I'm going to share with you some thoughts about imaging and physiology. And if you want a decent reference, I suggest that you look at the Lancet article that Giulio Guayumi and I wrote in 2017 of Lancet. So these are my disclosures. Intracoronary imaging and physiology are used to answer clinical questions that are shown on the left, and I will go through some of them. Randomized trials in non-left main lesions have shown that intracoronary physiology is the technique of choice in deciding whether or not a non-left main lesion should be treated, defer FAME 1 and FAME 2, and now define FLAIR and IFR Sweetheart show that IFR was equivalent to FFR. There are, however, some circumstances in which IFR may be superior to FFR. One in particular is tandem lesions, because the ability to create hyperemia or increased flow across one stenosis will be influenced by the presence of a second stenosis in an unpredictable way, and perhaps an acute coronary syndrome in which the microcirculation does not respond to hyperemia as well as it does in stable angina, such that event rates in deferred lesions in patients with acute coronary syndrome and stable angina are similar in IFR, but are somewhat different after using FFR. There are a number of other hyperemic indices that have been developed. Many people consider these to be equivalent and that this is a class effect. There are advantages and disadvantages to considering all resting indices to be class effects. Specifically, if one index fails, the others should also fail. So there are some arguments as to whether or not additional randomized trials should be performed with DPR, RFR, and DFR. We have tried for years to identify anatomic equivalents to intracoronary physiology in non-left main lesions, and these are some of the Ibis studies, but you can see that the minimal lumen area is the one measure that is consistent, but the cutoffs range from 2 to 4 square millimeters. The negative predicted value tends to be high, which means that in some cases it may be acceptable to defer intervention based upon a large lumen area. However, the positive predictive value averages only about 50%, which means it is never acceptable to decide to treat a lesion based on a minimal lumen area alone. OCT is no better than than Ibis in this situation. It's an issue of anatomy versus physiology. The main reason is shown in this slide. An elegant study from Jeju National University in Seoul, Korea. The amount of myocardium supplied by, say, a proximal LED is incredibly variable, and a minimal lumen area cannot take this into account, while physiology does take this into account. Left main lesions are somewhat different. 6 studies have highlighted the inaccuracy of angiography in assessing left main stenoses. For example, in the study by Lindstedt, 4 experienced interventional cardiologists agreed on the assessment of left main severity only 29% of the time, which means if you can't agree with your colleagues as to whether or not a left main should be treated based on angiography, how can you decide whether or not to treat that lesion? Here are 2 examples of ostial left main lesions. The top example was a patient who had bypass surgery actually twice for this ostial lesion back in the 1990s. This is a patient who had a pulmonary hypertension because of anomalous pulmonary venous return. And in both of these examples, Ibis showed that this is a normal left main, just an angiographic artifact. What technique should you use? There is equivalent data with FFR and Ibis, as shown by this elegant meta-analysis from Javier Esquinet's group. At 30 months follow-up mean, the event rate after deferral based on FFR and Ibis are about the same, which means that there is equivalent data for both. In order to use FFR, you need to understand some limitations, such as the presence of disease in the LAD. And in order to use Ibis, you must image from both the LAD and the circumflex, take the smallest lumen area, and make sure you disengage the guiding catheter if the lesion is very proximal. Another common question is, what is the culprit lesion? As shown in the Vanquish study, as many as 50% of ACS patients, particularly non-STEMI patients, have no identifiable culprit or multiple potential culprits. OCT is probably the technique of choice in identifying plaque rupture, plaque erosion, red thrombus, and white thrombus, certainly better than Ibis. Here's a clinical example with 2 lesions in the circumflex. The distal lesion looks more severe angiographically, but is in fact the more stable. The proximal lesion looks the less severe angiographically, but is in fact the less stable of the 2 lesions. The prevalence of OCT detected plaque rupture in STEMI is 70%, and non-STEMI is about 55%. We know that plaque ruptures in patients presenting with ACS should be treated, but there's emerging interesting data to suggest that erosions, the second most common cause of acute coronary syndrome, perhaps can be managed medically. This was first proposed by Francesco Prati, and recent data from Harbin, the second affiliated hospital of Harbin Medical University in China, the erosion study, suggests that this may in fact be true. I would not advocate doing this at the present time, but this is hypothesis generating concepts that should be tested in a randomized trial as to whether a ACS lesion with an intact fibrous cap can be managed medically rather than with obligatory stent implantation. There are other causes of acute coronary syndrome, such as a calcified nodule, shown here by Ibis and OCT. The first description of calcified nodules preceding the pathologic description came from intravascular ultrasound more than 20 years ago. And spontaneous coronary artery dissection rivals calcified nodule in terms of its prevalence. These are Ibis and OCT findings. When you see spontaneous dissection, if at all possible, the patient should be treated medically, assuming that symptoms resolve and ST segments come down. The reason is shown in this example. You can see resolution of the spontaneous dissection with complete healing. The segments of the coronary artery that dissect spontaneously and then heal do not develop recurrent spontaneous dissection. If the patient has a second episode, it'll be in a different segment of the coronary artery. Now let's talk a little bit about stent implantation. These are the predictors of early stent thrombosis and restenosis and MACE by Ibis and OCT after drug-eluting stent implantation. The number 1 predictor is stent underexpansion. The number 2 predictor is geographic miss. All other findings seen by Ibis or by OCT are either secondary or not important. The assessment of calcification by intravascular imaging is critically important because calcification is the major limitation to stent expansion. It is not the stent itself, it is the presence of calcium. Ibis can look at the arc and the length, OCT can look at the arc, length, thickness, area, and volume. And it is not until you get at least 3 quadrants of calcium that the angiogram even approaches moderate sensitivity. We showed this more than 20 years ago, and the exact same data was duplicated recently from our group comparing Ibis, OCT, and angiography. Here's a clinical example, a pretty decent angiographic result in a high-risk patient. Notice the Impella device. but on Ibis imaging, the minimal stent area is only slightly larger than the Ibis catheter because of severe circumferential calcium, something that was not seen angiographically, and stent under expansion also not seen angiographically. We have developed a calcium score to predict stent under expansion by OCT, combination of a maximum calcium angle of more than 2 quadrants, thickness more than 0.5 millimeter, length more than 5 millimeters. This combination is predictably associated with stent under expansion. I often show this slide. This is like a slide that this information came from the box of a stent that I just picked up off out of one cath lab, and looking at the minimal stent or the predicted minimal stent diameter by the manufacturer's compliance chart, say a 3.0 stent at 16 atmospheres, what does it actually measure by intravascular imaging? And the answer is 2.43 millimeters. Despite the fact that the manufacturers suggest that you should get 3.24 millimeters, on average it only measures 2.43. We have done this experiment many times. You achieve an average of only 75% of the diameter, 2/3 of the area predicted by these compliance charts, because the compliance charts were determined in air or in water, while stents are implanted into vessels with plaques. And the limiting factor to expansion is not the stent design, but the environment into which the stent is implanted. Using intravascular imaging, we can modify the procedure using higher pressures and larger balloons to achieve a better acute result. People often ask, where is the data? This is the data, randomized trials, meta-analyses, and registries comparing angiography to Ibis in white, OCT to angiography in blue, and data that has both Ibis and OCT data in yellow. Let's look at some of the data quickly. These are major meta-analyses incorporating both randomized trials and registries with Ibis, showing reduction of MACE, death, MI, stent thrombosis, and repeat revascularization. These are major meta-analyses just of randomized trials. And you can look at the largest randomized trials here. This is Ibis XPL and Ultimate, showing a 50% reduction in events at 12 months of follow-up. Almost identical numbers in these two trials, emphasizing how consistent this finding is. But it's most important to also realize you must optimize the procedure. If you optimize the procedure with Ibis guidance, you will have an event rate at 1 year follow-up of only 1.5%. If you don't optimize the procedure, the event rate will only be minimally better than angiography. Putting the catheter in the coronary artery does not improve the results. Optimizing the procedure based upon imaging does improve the acute results and long-term patient outcome. This is the largest meta-analysis comparing Ibis versus angiography, now 10 randomized trials, showing a reduction in cardiac mortality, of 56%, MI 45%, target lesion vascularization 43%, and definite probable stent thrombosis of 56%. What about OCT? There's obviously less data because it's a newer technology, but the one randomized OCT versus Ibis trial from Japan show identical event-free survival curves at 12 months. And this Bayesian meta-analysis, three-way analysis done by David Capodanno's group, show that Ibis and OCT are better than angiography, and Ibis and OCT are essentially equivalent. There are some subsets I'd like to mention. These are two meta-analyses in the left main, lesions treated by Ibis, again showing a reduction in all-cause mortality and cardiac mortality and MACE. The studies in these two meta-analyses are somewhat different, but the findings are remarkably consistent. Ibis is also incredibly useful during CTO intervention. This is an elegant review article by Fred Galassi. If you're interested, this is where I would start. And these are all the ways an IVUS can be used. Now, where is the data with OCT? There's been a randomized trial from Korea based upon either intention to treat or per protocol analysis. IVUS-guided CTO intervention is associated with a 2/3 or 3/4 reduction in events at 1 year of follow-up. And then another study from Korea, there's something called the CAMIA registry, which is an online national registry supported by the Korean NIH of patients presenting with STEMI, treated with primary PCI. And if you look at IVUS and OCT guidance compared to angiographic guidance, both IVUS and OCT are associated with a reduction in patient or device-oriented events. Patient-oriented events were mostly driven by a reduction in all-cause mortality. Device-oriented events were mostly driven by a reduction in cardiac mortality. So imaging-guided primary PCI, again, improves mortality. If a patient presents with contrast-induced nephropathy, a patient presents with chronic renal insufficiency and develops contrast-induced nephropathy, the mortality at 1 year of follow-up is 25%. You're better off not treating the patient than putting the patient on dialysis after a PCI procedure. How do you minimize this? Well, there have been a lot of studies and a lot of devices, but to our mind, the simplest way to prevent contrast nephropathy is not to use contrast. Now, people think we're nuts. This is easy to do as long as you develop the proper mindset. Ziad Ali published a series of 31 patients in European Heart Journal. The series is now over 100 and will be presented at TCT in the fall. What about bifurcation lesions? Here are 2 bifurcation lesions, one in the left main, one in the LAD, crossover stenting. Yet, how do you decide whether this is significant in the side branch after crossover stenting? The best way is physiology. The top example, an FFR of 0.93 in the circumflex, 0.92 in the diagonal branch. Why is this rarely significant? Because these are often angiographic artifacts. There's eccentric vessel deformation with little plaque shift. The changes are extremely focal, and the amount of myocardium is only modest. In reality, doing FFR of the side branch is rarely necessary. If there's less than TIMI-3 flow, you've got to treat it. If there is TIMI-3 flow, then you shouldn't have to assess it, and you shouldn't have to treat it. This is from Ajay Kurtanay's white paper in Circulation about CHIP, high-risk patients and lesions. This is the use of IVUS and OCT guidance according to the subset of high-risk patients and lesions, showing you how it is beneficial specifically in these patient subsets. The last topic I'll quickly touch on is causes of metallic stent failure. Whether bare metal stents or drug-eluting stents, they present either with stent thrombosis or restenosis, and they can present at different time courses based upon the underlying stent type, the clinical presentation, and the time course. You can have a differential diagnosis clinically of the causes. If I had to pick one technique to assess stent failure, and I believe all stent failure should be assessed, it's OCT. Because OCT can see certain things that cannot be seen reliably by IVUS. In particular, uncovered stent struts and the presence of neoatherosclerosis, although NIRS IVUS is also good for assessing neoatherosclerosis. Stent under expansion continues to be a common cause of in-stent restenosis, and in fact, it's probably an increasingly common cause. If you compare stent under expansion after bare metal stents, first generation DS and second generation DS, you can see that stent under expansion as a cause of restenosis has increased. Simply, we have gotten sloppy. We think we have better stents. It's not necessary to expand them as well, and that simply is not correct. This is data from the Prestige Registry looking at different time courses of stent thrombosis. after DS implantation. And if we just look at very late stent thrombosis, you can see the appearance of neoatherosclerosis. That is the appearance of neointima that fits the criteria of a vulnerable plaque or vulnerable neointima. The Pittock neointimal rupture, and thrombus formation. This can be seen as early as 3 months after DS implantation, although it averages probably about 18 to 24 months in terms of its occurrence. Once a patient develops neoatherosclerosis, either by angiography shown here or more commonly by OCT, the survival is markedly reduced compared to the absence of neoatherosclerosis. So as I mentioned, these are clinical techniques used to assess different clinical issues, answer different questions in the cath lab. And these are the techniques that are available. FFR or resting indices, Ibis OCT, and some assessment of plaque composition. For example, non-left main lesions, physiology, left main lesions, FFR and Ibis. There's no data on IFR. Optimizing stent implantation, Ibis and OCT seem about equivalent. Left main better with Ibis, minimizing contrast better with Ibis, assessing stent failure better with OCT. So it's only in the cath lab do we look for a single modality to answer all the questions, which is the legacy of coronary angiography. You don't do this in any other part of medicine. It is important to know which patient and which clinical scenario will benefit from which imaging or physiology assessment. So to me, the argument is not FFR versus IFR or other non-hyperemic pressure ratio index, but physiology versus angiography. And the argument is not Ibis versus OCT, but imaging guidance versus angiography. 90% of your needs can be addressed with one physiologic tool and one imaging tool. You should pick one and get good at it. So what is the problem? Cost, which I understand, and in some devices imaging devices are more expensive than stents, at least in some countries, and education. Education is critical, and I think we've done a pretty poor job. I think that's because most interventional fellowships do not require the fellows to learn imaging and physiology. And if they don't learn it during the fellowship, they're not going to adapt it when they are done. We have proposed and demonstrated the effectiveness of a cath lab-based imaging program that is based on non-physician directors and experts, perhaps supported by technicians and fellows. We started this in Washington Hospital Center, continued in Lenox Hill, and now in Columbia, and it's been adopted at Erasmus University in Rotterdam. It is effective if you have a cath lab that's large enough to support such an individual, and these individuals can become your partner in the procedure, understand the equipment, setup, and image and data interpretation that allow you to optimize the procedure and improve patient outcomes. Thank you for your attention.
Thank you, Dr. Gari, for excellent lecture on comparing the both outcomes, and final message is that whatever modality you're comfortable with, you can use. It can serve 90% of the times answer, but the idea is to use it and take appropriate measures after what they infer. I think he will be available with us for another 10 minutes. We requested him to stay for 10 minutes of discussion. If any of you have any questions or comments to Dr. Gari, please feel free to question. Can you pass on the mic in the hall? Any comments, Dr. Lucas or Sushil?
Well, what I have in common is just say thank you for this summary of all the evidence available. And I have to say that I'm still wondering, because sometimes it happens to me that I still have colleagues asking for evidence about imaging, evidence about physiology, evidence about this, all these adjunctive devices. And I always ask myself, there is a matter of communication, because for some reason still the interventional cardiology community does not know all this huge bunch of evidence. And I have to say that in this perspective, we need to do something more. because we have evidence. We have all we need to increase the penetration of all these devices. And I have to say, even in those countries where budget is not a problem because there is a specific reimbursement, still the penetration of imaging as well as physiology is definitely very low.
Can I ask Gary a comment on that? Do you think that's an education, your last point, right? There's, you have sometimes information overload, and people are not educated how appropriately to use the data, and that's why they don't use it, or what are your thoughts?
I think there are two thoughts. I think education is an issue, especially in the fellows. We have surveyed fellows, and we can document the fact that they're not getting trained. In general, 1/3 of fellows do not get adequate training in physiology, 1/2 in Ibis, 2/3 in OCT. And we've got data to prove that. But there's also a psychologic component. I think the interventional community has convinced itself that these are not important, and it's very hard to change somebody's mind once they have a negative impression of something. And the psychologists have shown this again over and over again. You can take somebody who believes in something and convince them that it's bad, but once somebody believes it's bad, it's almost impossible to convince them that it is good and necessary.
Do you think all of these programs, whether it's FFR or Ibis, are adding on adjunctive tools, right? The co-registration with fluoro, giving the length of the lesion, looking at stent deposition to make the procedure easier. I mean, for me, those things add value, and for a site to invest in something, the added value of some of those features may push them towards one direction or another, and it may push them towards using it. I mean, in India, it's a cost issue. I think it's a big cost issue, and that. There's only so much you can do about that. Patients are paying for these things. But when it's not a cost issue, those adjunctive tools seem to help, at least, maybe convince people to use it. Maybe some comments from the panel. Go ahead, Gary. Sorry.
I think that's correct, but I also think that I think the impact will be somewhat limited because the largest adoption of these devices. I mean, Japan has a 90% adoption of imaging. Korea has a 35 to 40% adoption of imaging without co-registration. So I do think it's mostly a matter of education. I would like to think that co-registration will help, but it's got to be easy. If it's complicated, no.
Any other comments from the panel? Or
other important aspect of benefits versus problems, OCT is actually more user-friendly, and this angio co-registration and all help us to learn it better. Wherever you have a doubt at that point, and you can do that, and probably in Ibis also they're trying to do something like that. One thing new which we learned out of your lecture is they have studies to show that even in ACS, acute coronary syndromes, MIs, then there's data coming up with that imaging helps. Before we close, Dr. Gary, we really liked your way of presentation. Another way to learn from these masters is he has put all the important headings on the left and they enunciated each of the 8 in detail on the right. The type of presentation also is quite appreciable. Thanks for your valuable time. And I would like to inform all that they were kind enough that anybody through FACS Foundation comes through, they would offer that imaging fellowship if any of youngsters are interested at the CRF and the lab. Thank you. And any further closing questions from the audience?
Make one other comment, Gary. So, part of the goal of this TCT India is to sort of encourage, a stepping stone, and maybe there's more value by attending TCT in San Francisco. If people here that are doing interventions want to get more in-depth, more understanding, more knowledge. I understand, obviously, the best way is a dedicated fellowship, but people can't do that. Is there, can you summarize what, from TCT, is there like a tract, if they want to dedicate and focus on imaging, I know it's hard in 2 or 3 days, but what can people do?
So at the risk of angering everybody at CRF, that's not the way to learn imaging. I summarized all the information on intracoronary imaging in about 15, 20 minutes. There'll be in-depth discussions of just about each point that I made. But unfortunately, the only way to learn imaging is to learn to interpret images and learn how to use it. It's hard to attend didactic conferences that do that. I actually think that these are better done locally, and they have to be case-based. Everybody wants to give lectures and show data. Lectures and data don't teach you how to interpret and use images. You learn to interpret and use images by learning to interpret and use images, either in conferences, case-based presentations, or even better in the cath lab. And I really applaud our colleagues in India if they would go ahead and develop that kind of a program. Maybe not obviously a dedicated long-term fellowship, but even a week-long program where there are cases that are reviewed again and again and again and teach people how to interpret the images, how to use the information. Yes, there'll be stuff at TCT for sure, but the only way to learn to interpret images and to use them is to learn how to interpret them and use them.
Great. I think that's a great point. And Gary, thanks again for doing this webcast. It was a great summary and overview of everything.
Thank you very much.
Thank you very much.
Thank you, Dr. Gary, for your kind time sparing and always encouragement for our local meeting here. And thank you once again. A big round of applause to Dr. Gary. Right. Thank you, sir. I think we can break.
Great.
Right. We are about to go for live cases which are coming from Kolkata and Chennai. Before that, as one word, basically what we wanted to mention, we are trying to do something passionately about the imaging too. The FACS Vascular Academy, which will be up running from 1st September. We have OCT, Ibis, and each of these fellows who are passing out, who are not getting exposed to this imaging modality. We are developing a one-week program where initially you have lectures for one day, and then you have a hands-on on the animal lab, which we have developed on the sign models you'll be made to do. And then we'll also practice doing stenting and imaging post-net. And finally, last 1 or 2 days, we are trying to get you into some busy labs so that you'll have at least a feel. And some of the fellows who are not exposed to this could benefit by this. So this is up and will be coming, and various industries will help you in getting your fellows trained. I think with this, we'll go on to the live cases coming up. Next set of live cases. Thank you, the present chairpersons. I think Dr. Sushil will continue. And the next set of chairpersons, please join. I think we also have Dr. Mirasello here. We request you to join for chairing the next live case, sir. Don't mind. Next set of live cases will be from BM Birla Hospital. Dr. Diman Kahali will be doing it. Dr. Anand Ganraj from Apollo Hospital, Chennai. Dr. Sushil will continue. Dr. Mukesh did in place of Dr. Kondala. I saw Dr. Kondala here. Can Kondala join here on the chair? There are other panelists around who have mentioned, please join. Is Dr. Jain Arkajan here? CM Nagesh, Vittal Bagi, Kathireshan, Harikishan, Anwar Khan, Ramchandra Rao. Anybody is here, please join. Over to you.
Rocco.
Hello. Hi. Can you hear us?
Hello. Yeah. Dr. Kahali here. Happy welcome to the city of Joy, sir, and welcome all the panelists, Chair, and TCT Srinivas, Gary, and everybody over there. Can you listen to us?
Yes, we can hear you and see you well. Do you want to introduce the case to us?
So, yeah, sure. So this is a 63-year-old gentleman. Where is the and admitted with severe angina, and the patient has a severe COPD as well. So we took a heart team approach, and the patient is diabetic, uncontrolled diabetes. Patient has severe COPD. Patient is history of hypertension and was admitted with CCS class 3 angina. His ejection fraction is good, and he had a stenting of LAD in 2008 in SSKM hospital, and then in 2015 he had a repeat angiogram which showed a moderate lesion in the left main, 40% like that. But when we did the angiogram this time, we found that left main ostium has a very tight 80-90% lesion, and the patient was having severe angina. So we took a heart team approach. We took the opinion of the surgeon, but surgeon told the patient has severe COPD, so better you go for ostial stenting. And his RCA also shows a tight lesion at the origin. So we did a RFR because the patient has COPD. We didn't want to give adenosine. And RFR shows the value 0.97. We have done 2-3 times, and it is 0.97. So just now we are listening the virtues of FFR, OCT, etc. And just now we did the RFR over there in the right side, RCA. Show the RCA, na? Show the RCA. Show the. Yeah. And
I think that's an interesting point, right? So if you look angiographically at that lesion, most people would agree that it was tight. Do you have the tracing for the IFR, or can we see the tracing? Or
yeah, we have the tracing. Can you show the tracing, please? Yeah. Can you show the tracing, please? Yeah.
It'd be useful for education.
So this is the RFR. Yeah.
Very good evening.
So the RCA proximal lesion spatially looks to be quite tight. But that is the virtue of FFR, that we did the FFR, and it is irrelevant. It is 0.97, you know.
That's good.
So the value for RFR is 0.89 instead of 0.8 with FFR, and it was 0.97. So both the times it was high. You can see it, and there is no gradient across the mid RCA lesion as well. So no question of intervening in the RCA. So we have to be content with doing the left main ostium.
One comment here.
So we have put a BMW where, because...
One moment, just wanted a quick discussion from the panel. One comment here.
Yeah, very good evening, Dr. Kahali. Here's Dr. Ferenc from Germany. So I was, I think, last year in
Dr.
Calcutta.
Ferenc, how are you? We
Fine,
met in
thank you.
Europe PCR.
Yeah, exactly. Thank you. Thank you.
This night when you talked that you'll be coming to Hyderabad.
Yeah. Thank you. Really nice to see you again. So the question is...
Dr. Ferenc,
So I think the right is very clear. I think that's a clear statement, and it was really good to make IFR for safety reasons. The ostial LAD, ostial left main lesion is clear. There is probably also problem of the aorta ascendens. Did you perform CT scan to see there's a porcelain aorta? Because we have to put stent, which is large, which has good radial forces, you know, which doesn't collapse.
Yeah, that's a good point. There's a calcium on the angio at the ostium of the left main, and I think that's relevant in terms of, but it doesn't look like it would be circumferential, but in terms of expansion and strength, those are obvious concerns. Just real quick for the audience that doesn't do, if you're going to use a tool like IFR or FFR, it needs to be done properly, especially for ostial lesions. You want to make sure you equalize the catheter in the aorta, not after you're already across the lesion, because you have to equalize in the aorta You have to engage, flush, disengage the guide when you do the readings. And so then if you don't do the readings properly, then you'll get false readings. So I think, especially for osteal lesions, those careful techniques of equalizing in the proper place, flushing, disengaging the guide are important to make sure.
What is really helpful if you take access support wire, first of all, standard access support wire put into the vessel, then you stabilize the guiding catheter, and then you can very easily go outside the catheter with a FFR wire and equalize whatever you do. This is, I think, a small tip for the.
So
that's a great suggestion.
So can you tell how should we proceed? What's the opinion of the panelists?
So I think this very clear, highly significant osteal left main stenosis. So we have to treat. This is very clear. I think we need quite a short stent, but the stent must be placed perfectly. So you need maybe a 1 millimeter stent must be outside into the aorta to be sure you don't let some gap.
But there's also disease, as you mentioned, distal. Like there's also disease in the distal left main proximal LAD. And we had a live case in the first session talking about left main intervention. And there's a lot of discussion about whether imaging prior to stenting is mandatory to understand what you're doing. So imaging the osteal LAD, the distal left main, and the osteal left main may add value here.
Yeah, after opening the left main, because the LAD, the left main is so tight. So first we want to dilate the left main with a 3-9 balloon, not 3-9, 310 balloon.
Yeah, I think that's. I think that makes sense. It makes sense to avoid ischemic events. So I could remember, I think last year I had similar case, and there was a fibrillation, ventricular fibrillation, so stress.
You got to be careful in these lesions.
So I believe you go with 3.0 non-compliant balloon just to open the ostium.
The calcium there is a marker, so I would probably come back a little bit, right? You can see that calcium nicely there. And we talked in the cranial views are sometimes useful for these as well, LAO-cranial especially, to lay out the ostium.
You go to the cranial view, 30 degrees. This is cranial view, And in all the views, the lesion is not so prominent, but in this view, it's very prominent. So, dakho. So, there is calcium over there.
I think you have to go still. No, it's not bad. Maybe millimeter back.
Yeah. We are going to dilate the lesion.
This is, maybe you could go to LAO cranial. LAO cranial will be even better. So this is non-compliant balloon or semi-compliant? I'm not sure.
It's a non-compliant, I think he said it's a 3.0, So you can see the blood pressure came down. So in some of these scenarios, you want to give short breaks. You don't want to be occlusive for a long period of time. If you see the pressure coming down, you want to come down with the balloon quickly. Pressure's down a bit here, so I would probably come down with the balloon, reperfuse. Then in this case, you got to get the guide catheter out, and disengage the guide.
Pressure is coming back, okay.
Coming back. So again, you got to pay. It's as they're showing here. You got to pay attention to the hemodynamics. If you see the pressure dropping, you know, short inflations, disengage the guide between inflations, allow reperfusion to occur. If the pressure's not recovering, do a shot. Make sure there's not a dissection. It's extending down the circ or LAD. But now you see the pressure's recovered nicely with just a short rest.
But to be honest, I think we didn't reach enough with 3.0, so probably we have to take even bigger balloon to make one more sufficient predilatation. So I would suggest to go even with minimum 3.5, maybe 4.0 non-compliant balloon. It will be my suggestion. Can you hear us? I think there is no connection.
Can you hear us? Did we lose their voice? I think we lost the audio from the site. Is that right? Srinivas? Yeah. Okay. Well, we can't hear them, but we can at least see what they're doing in the meantime.
No, that's obvious. We lose audio. So I personally would go with a larger balloon before I would choose the stent. And now the question is, there is a osteal main problem, but if you see in this projection, complete left main is diseased. Yeah. And this is exactly the question, should we cover complete? Maybe we could have one more projection to decide, do we have to involve bifurcation or even not?
And it's important to keep in mind, the point you raised earlier is an important one. This is a lesion that may not be in the vessel, it's in the aorta. Right, and the aorta is a different entity, different fibroelastic structure than the coronary arteries. So this is an aortic lesion that you're trying to stent, essentially. So you may get expansion of the balloon, but it may recoil because that's just the properties of the aorta. So you can. There are several approaches, and I think taking a larger balloon just to make sure you can expand is very reasonable. Running the Ibis quickly. So when you do an Ibis here, I would just do a quick pullback or even manual right at the aorta, so you're not creating ischemia for a long period of time, if that's a consideration. Or you can just, do a larger balloon and then just take a stent, fix the aorta, and then fix the lesion, and then Ibis after as well.
I think what is very, once is clear, OCT doesn't make sense here in this scenario, right?
Yes.
So only quick, fast Ibis will be helpful, but they have probably one bigger balloon.
Yeah, I'm assuming this is a bigger balloon.
Do we have chance to get audio connection?
So again, in this patient, the right coronary is essentially non-dominant. I think it's slip distal.
Slipping,
yeah, slip distal.
So one more option is, or help is, if you take longer balloon in this case.
And hang out the aorta.
So I would suggest minimum 15 or even 20 and hang to the aorta.
Right.
This will be definitely also some additional information regarding the needed length of the stent.
So it may be worth one more inflation, centering the balloon on the calcium.
Yes.
Since you already have the balloon there.
But I think the lesion starts even before this calcium marker, So the patient is, as we can see at the moment, very stable. That's fine. And maybe the lesion is oval, so maybe they could make fast run with Ibis to see how it looks.
Today. It's out of order. We have an OCT.
Oh, I see. Okay. This is not working today. There.
Okay. So,
yeah.
So if you don't have Ibis, then there were very clear suggestion from my side. So you need a longer non-compliant balloon. You have to go with a balloon a bit more to the aorta, and then I would go at least with 3.5 or better 4.0 non-compliant balloon.
Just we went with a 4 millimeter balloon, 410 at 12 ATN.
It was slipping.
The second one.
Yes, we were just commenting that it seemed to have slipped watermelon seated distal, so maybe did not get the lesion.
Second, we have to keep it there. Of course.
So you put one wire more?
Yeah, we are putting one wire more, yeah.
This is also optional.
In this scenario, any cutting balloon is like even after 3 balloon, the osteal left main not will get.
I would be worried about doing it at the left main ostium. I think the risk of a dissection, potential risk of injury to the aorta, I would be cautious about it. But it's a valid point. Angiosculpt or cutting balloon would be more stable. But I think if you take a longer balloon and hang out in the aorta, you can accomplish what you need to.
This will be the next step, definitely.
What? Huh? Take it in the key, for the cursor. Okay.
So would you like to place wire in the syrup?
Regarding 10 what size you want to give?
So maybe they just place wire in the aorta to have information where's the ostium, you know, because they are not in. Are they in the circ? I'm not sure.
Where is that wire? Is it in a left atrial branch or is it in the aorta? Aorta.
Yeah.
Okay.
Yeah.
But that's actually conserve a purpose as well, because that helps delineate where the ostium is.
Once again, I would go to definitely to LAO cranial. This is the best projection to have a very clear information regarding the left main ostium. LAO 30, cranial maybe 25-30. That will be my personal recommendation.
I think the osteal left mains, the LAO cranial is the best view. In the majority of patients. Obviously, there's some patients, this gentleman has bad COPD, whether the heart's rotated or not. Here it's a little bit not, maybe less LAO and more crani will help, because you're overlapping here a bit.
Exactly.
We lost him. I think we lost the audio again.
Less LAO, please, and definitely a bit more cranial. Then it will be nice.
Okay. So we are planning to take Giant's expedition 4x12.
We cannot really hear you nice.
Can we turn the site's volume up?
Yeah, sir, we want to take a 4x12 Giant's expedition. Is it okay? Because dilating with this balloon, scored balloon or flexitome, there may be dissection. So which side stents do you advocate? Can you listen to me, sir?
Unfortunately, we can't hear you well, so.
Yeah.
But Kahali, we are not able to hear you well. That's why they now respond from this side.
Yeah, I am talking, but I think it's not going. I can intermittently listen to you. Sir, I was asking what size stent would you prefer? Because we would like to put the stent, and if required, we'll post-dilate.
Yeah, I think you can go ahead with your plan. When we are able to hear better, we'll start communicating. We'll keep discussing with you. As of now, what we understand is you're trying to take a 4 into 10 stent and probably stent the ostium.
Expedition, yeah.
Okay?
Yeah, I think that's fine. If you take a 3.5 or 4.0 by 12, I would do 4.0. Something a little bit longer, because you need to hang out about 2 millimeters. You need to be proximal to that calcium.
Did you hear that suggestion, Kahali?
Yes, yeah. Because advocating 4.15.
I think to take too short short stent will be difficult.
It tends to milk out also sometimes.
Yeah, it's really problem for dislocation.
He has taken your advice and changed to 4 into 15.
Longer, it makes your life easier and safer, more safety for the patient.
The other case here, you have to, it's a longish left main, so even a 15 won't cross over the circ. So even if you want to stay short of the circ, it should be fine. Hang out 2 millimeters.
The length was 14, so we chose to take 4.12.
4.12, okay.
Hazard, yeah, 4.12. So
12 is better because 8 sometimes tends to slip unless left main is very short.
I would never do an 8.
Not very short, sir.
No, 12 is better.
Yeah.
So you have which diameter? 5.0?
4 millimeter.
4.0, 12.
Take it up. Alright.
And then
so you go to that.
I would go back to your other view and check. Your left main, you want to get orthogonal views and check multiple projections before you deploy.
Yeah, we are going to RU, sir.
Yeah, sometimes epicaudal projection is also helpful. But definitely to check him in 2 different projections is essential.
We have to come back a little, I think.
Yeah, probably caudal view to check distal position and cranial views to check the ostial positions are better.
I think it needs to be a little bit more distal.
Oh, this itself is just short.
I think.
Could you check again from distal view? Caudal.
Yeah.
That's not sure.
Caudal view. Go to the caudal one. It's negative korecho. Negative korecho. Huh? Do what?
I think it needs to be a little bit more distal. I don't know. What do you guys think? It's hard to see here, but.
Sine.
No,
it's not seen.
Definitely.
I think it needs to be more distal now. Yeah.
Maybe RAO caudal sometimes.
Yeah.
RAO caudal.
So the hemodynamics are good. These are the times you want to take multiple views and make sure you're comfortable with the position, right? The hemodynamics are good. You're not rushed. Take RAO caudal, AP cranial, all the different views to reassure yourself.
No, you have to come back.
I would get the guide closer to understand where the ostium is as well.
You want to disengage a little more?
I think second wire is just confusing. It's not helpful.
So
go a
could
bit
you take it out?
Closer to the
Is it
ostium.
all right? Let me show.
Yeah, it's too far out, I think.
Yeah, you have to go more inside.
Yeah. You can see the length of left main that you have beyond your stent, right? So you know you have to be a little bit more distal based on your initial angio.
Yeah.
That's the importance of checking distal position in the epicaudal or caudal view compared to positioning checking in cranial views ostium.
They have to come back a little, yeah.
Distal will miss.
Huh?
Distal will miss.
I think once check cranially, position it correctly, then you check once caudally. This falling short, we can always change because left main.
Yeah.
So if you have sometimes problems like here in this situation, it's really not easy. Yeah? Not
so is it all right, sir? Can you see?
What you could
we have
do,
come out and we are
with a stent
1 millimeter
inside,
out of the.
Go closer with a guiding procedure to the osteum, and then trying to going back on the way back. Try to get the best position. And as you told, absolutely correct. Definitely check the projection in different multiple projections.
I mean, I think the other wires may be hurting you. I'd pull the other wire back. I'd advance the stent distal into the left main, get your guide close, see where the true ostium is, and then back your guide out, I think. It might be more useful.
Yeah. We can see the ostium, sir, clearly.
You're too far back, because if you look at that calcium, so here you see that calcium, right? The calcium is at the distal part of the stent.
Back,
You are too much in the aorta.
Yes.
Definitely, a minimum 2.5 millimeter.
Even more, I would go further. Yeah, right there. Now it's closer.
Are you happy with this position? Let us see.
Areocranial.
I would still go in 2 or 3 millimeters, because if I look at the calcium.
2 more inside, 2 millimeter more.
And then I would check crania. I would go in 2 or 3 millimeters, do one check, angio here, and then check crania.
Good injection.
Now go more inside. Because nothing can happen, you know. It's
As they're doing it, can we move to Chennai for seeing them for 20 minutes and come back here? Is it done, Dr. Bhatia?
Okay, sir.
It is okay. It's okay.
No, it's okay, no?
It's okay.
It's okay, sir?
No, not sure. To be honest, I'm not 100% sure. I would suggest you are still too much inside the aorta.
Just take elaeocranial view once again. Elaeocranial.
Yes, elaeocranial, but not so much LAO.
If you see that calcium, the aortic marker should be about 2 millimeters proximal to that calcium. And right now you're in the mid portion, I think. So I agree, I would probably go in a little bit.
Give a good injection.
Let's see this view.
Less LAO, it's too much. Less LAO, more cranial. Could you go a bit less LAO?
20.
Now you could have impression you are already too deep in the aorta.
Yeah.
Okay, check here. And go with the guiding a bit closer to the left main, please.
I think your stent is out about 5 millimeters, so I think you need to go in.
Not so much, but
I think, sir, it's okay.
You please go inside a little more, sir. It's protruding too much into the aorta. It is protruding too much into the aorta.
This is a good view. This was the best view I think.
Half of the stent is inside, half is out of the aorta. Plus, go 2-3 mm more.
It's not moving. Yeah.
No.
It didn't move.
Put both into the left main, so both stent and the guiding, and then on the way back we make measurements.
Okay, that moved. Now you're good. No, because you're near the calcium. No, now it's coming back again.
Okay, now again.
It came back. Yeah, unfortunately.
Make a movie.
No, it didn't. It came
Go
back.
inside again. It came back.
Came back, yeah.
The way it is jumping also suggests that it is coming back.
Yeah. I would also recommend to use EBU guiding, it will be more stable because this one
That's
is just
closer.
jumping.
Now take a shot there. Don't move anything, just take a shot. And I think this is close.
That
this
is
is fine.
better.
This is fine.
This
Best.
is much better.
Yeah.
So I
Much
think
better.
it's okay, sir.
This is better.
Yeah, much better, yeah.
Please go ahead.
So we are inflating the stent, sir.
Yes.
Yeah.
Okay, we are inflating.
There you see it.
Calculate
Yeah.
Pressure looks okay.
More back.
Came back.
Still better.
Missing here.
Okay,
Okay,
so
pressure's down.
what is your pressure now?
Blood pressure is coming down, so
dropping,
come down with the balloon, I think. Yeah.
It has come down to 80, 90 now.
90.
85, 90, 100.
Okay. Okay, and now get the
So
balloon
we want to
out.
give another inflation.
Still flaring.
Yeah.
Yeah.
Yeah, we'll do it, the flaring after this one, yeah.
I think in many cases what I saw a few times, at least in 5 cases I saw, it
Yes,
was
yeah.
4.0 stent in 5.5 left main, and
So we
then
are
the
flaring,
stent,
yeah.
because of movements, dislocated. So, but here we have calcium. That's
Yeah,
good.
yeah,
Okay,
yeah.
that's calcium is stabilizing. But I would suggest to take care, take 5.0 non-compliant balloon and make
Take a
proper
4.5 or at high pressure or 5.0.
right,
And,
minimum 5.0. I think
we'll have to move to the next case. Maybe we can take one picture with the balloon down and take one and the balloon out.
Okay, yeah, we are, yeah. The picture.
That's much better.
So you have to
you
go
need
with a higher balloon.
non-compliant balloon and
Yeah.
then everything will be
Yeah.
perfect.
Thank you.
So we're going to move to the next room, but the suggestions from Dr. Wentz
Okay, sir, okay,
is
thank you
to
very
take
much,
a
sir.
4.5 or 5.0 non-compliant at the ostium and hang it out into the aorta just to flare the ostium a bit more and give a better result. But that's a nice example of a tough osteo lesion. Thank you very much.
Thank you, sir.
Thank you for joining us.
Thank you, Dr. Pennick. Thank
Okay.
you, all the
Thank
panelists.
you. All
Can
the
we
best.
move to Chennai?
Thank you, sir.
Yeah. Dr. Anand, we are able to see you and we have Dr. Sushil Kodali, Dr. Meresalo, Dr. Kondal Rao and other doctor with me. Please introduce your case and go ahead.
Sorry we're late, and thank you for joining us so late in the evening.
4.5 বেলুন লাগবে 4.5 বেশি বড় দিও না 10ই দাও ঠিক আছে
Please disconnect the audio of Kolkata and give this.
One second. We have the audio from the other
Play
side.
the PowerPoint.
Now we can hear you. Please go ahead.
Yeah, so we'll show you introduce the case. It's basically a 64-year-old diabetic female who had an acute coronary syndrome probably 2 years ago. If you can see the history, and at that time she was not evaluated and managed medically. Then she had another episode of unstable angina in January. This was an NSTEMI and again managed conservatively. Then had the angiogram in April 2019, which showed a LAD CTO, mid LAD CTO, a critical osteoproximal LAD, and an RCA CTO with some circumflex disease. We will play, can you go to the next slide, please? So this was the angiogram that was done in April. You can see
you talk a little louder, please?
disease and the...
Dr. Anand, can you talk a little louder?
So circumflex disease is...
Yeah. Oh,
yeah.
Better.
Increase the audio. Audio. Yeah. Okay. Yeah. So you can see the osteoproximal LAD disease and mid LAD CTO. Next slide, please. And the big septal filling the right, because the right is a very large vessel with the CTO in the mid segment. Next. And the LAD is filling from homologous collaterals. Next slide, please. Next. So this was the RCA.
Need to
so
work
the patient
the
was
entire...
advised surgery, but did not go for surgery for the last 4 months. So now she is on the table for PCI. So we started with the diagnostic. Can we switch to the live fluoro, please? First line. Yeah. Live fluoro, please. Yeah.
This is one where you probably don't want to calculate the syntax score because you don't want to know it.
It's better not to calculate, but once again, how is LV function? How is LV function?
LV function is about 50%.
50.
She has chronic stable angina. Yeah,
did you
50%
consider
with some regional wall motion in the anterior wall?
Yeah. Did you consider
Pardon?
did you consider to use here protection, protected device, impeller, something like this? Is this an option for you? Because this is really
because the
difficult
LV function
situation.
was adequate. We didn't really think about it. And the CT was also probably is not so complex, but we might have to step from left main because of the angulation and the osteoproximal disease, and it being a right dominant system. Here we are.
The problem of using impeller in our country is too expensive for us. Patient, it'll be 3 times the cost of the PCA procedure.
Yeah, I know, but you know, if the patient die on the table, the problem could be even larger. I'm working in Bad Kreuznach Heart Center, Bad Kreuznach. So this is